من قبل وأكررها ثم أكررها. يوما ما ستصبح هذه المحاضرات المرجع الأول للكوميونيكيشن سكيلز دون أي مبالغة ولا أدنى مجاملة، فستذكرون ما أقول لكم.
بسم الله الرحمن الرحيم. First of all, I would like to thank all people shared in my course, and I have to say a lot of time shared in these discussions and the courses, and all of us worked together as a team. The next generation that preparing for basis, they are lucky, because if they heard the discussions and the lectures, they will take a lot of benefit from this discussion, not from me only, from all candidates participate in it. We have a good person that participate, and we have a pioneer doctor participate in these discussions. And I would like to say I have to give a special thanks to Dr. Ahmed. This great person, he recorded all cases and all scenarios and keep it with him. Next generation will take a lot of information from this record, and may Allah, our Allah and our God, give him a lot for his work. Once again also, I would like to extend my thanks to Dr. Ahmed for his effort and for his caring to collect all videos and all lectures and upload it on Facebook or YouTube. And also he has a lot of suggestions, and one of these suggestions, this is a lecture that I'm going to do it, to take a benefit, to give a benefit for all candidates. Thank you, Dr. Jamal. Thank you, Dr. Ahmed, for your efforts. First of all, I am really pleased to have studied. I am confident that by doing this course, you will give yourself the best chance when the exam day comes. How you guys cases. There is some keys of pass cases. First key is identifying your goal and you should focus on your goal. You have to make a plan you have to follow instructions. You have to train the way you want to play. You have to make rehearsal. You have to turn your weakness into your strength. You have to avoid negative self-talk and negative verbalizations. You have to monitor your workouts and evaluate your progress. This is some keys to the spaces. I will speak about it in details. First one, identify your goal and maintaining the focus in your game. Our goal to the spaces from the first attempt. You have to focus on your game. The single most powerful predictor of success in the long run is commitment. Everyone wants a quick fix, but that is as unrealistic for improving your clinical skills. If you watch what someone else is doing, then you are not focusing on what you need to do. We have to learn from others, but we have to improve ourselves. Just because someone passed the exam, don't assume it was easy for them. Success is not a matter of luck. Discipline is remember what you want. The only discipline that lasts is self-discipline. Keys. Planning. You have to make a plan. Make preparation in advance. You will never have trouble if you are prepared for it. Failing to plan is planning to fail. The chances of success are definitely increased with proper planning. Plan each and everything to its last detail, and this way you will definitely reduce your stress levels. Concentrate on your preparation and will be able to keep unwanted situation at bay. You have to make for yourself long-term plan and short-term plan. Long-term plan: review all tests, review notes daily, and keep up with practicing. Join a study group. Short-term plan: 1 week before the exam, prepare a study schedule, rapid review of all stations, review your notes. Try to be near from optimistic candidates. Follow instructions. Follow instruction of expertise person. Follow the philosophy of do it now, do it right. Follow instruction is a relatively simple, but it is very important skill. What kind of person do you want to be? you want to change the kind of candidate you are, change the kind of person you are. You are what you say and do. Train the way you want to play. There are two phases of our mind, conscious mind and subconscious mind. Subconscious mind is the unseen phase of our mind. It knows no limitation and has the capacity to accomplish all of our goals and ambitions. Your subconscious mind is at work at all time. It doesn't matter if you are awake or asleep. Let's see how we develop any new skill or habit. Initially, when we are learning the skill, we are using our conscious mind all the time. Later on, with repeated practice, we rely less and less on the conscious mind because our subconscious mind takes over the task and it allows us to perform the skill without much thinking by the conscious mind. You learn any skill with your conscious attention and with sufficient practice. This handed over to our subconscious mind, and when the moment comes, the task or the skill is performed with perfection. In practicing your clinical skills, you need to do the same things in the same way as you when you use them in actual situations. Learning doesn't occur as a smooth, seamless, steady process. Learning involves integration of new information with existing information. The brain needs time for restructuring. The brain needs time for restructuring and consolidation. It takes time for the brain to accommodate new input. Make rehearsal. It is the fifth goal. It is the fifth steps in the preparation process. This means imagine yourself doing something successful before you actually begin it. It's like a move you run in your head. If I can conceive it, I can believe it. If I can believe it, I can achieve it. Repeated practice, both mental rehearsal and actual practice, can do wonders on the day of exam when you are performing in front of examiner. It is very important for the conscious mind to concentrate on the task it's facing and not think of anything else. If you have done your homework well, done enough mental and clinical practice, on the day of exam, you will be concentrating on the clinical skills, science, and at the same time, your examination sequence will be effortless. think what is going to happen if you turn your weakness into your strength. Look at things you feel uncomfortable doing. You find frustrating or you feel you are not good at. It's important that you don't ignore these things with a hope that you may not encounter this in the examination. These are the things which can decide between a pass and a fail. Number 7, avoid negative self-talk and negative verbalizations. Many candidates have the habit of negative self-talk. This is too hard. I will never get this. Or this is hopeless. Whenever you have a thought like this, please stop it. Number 8. Fill up your workouts. Assess your own performance. Know why you missed an item. If you don't find out why you missed the items, then you will have lost the opportunity to learn, and you have wasted the time you spent doing the activity. This is 8 steps to pass basis. The next is move. Now is your step. If you did all steps, be sure and confident you will pass. Once again, congratulations on your participate in my course. I am excited about the opportunity to share my information with you. This is the introduction, how to prepare yourself to pass an exam. Again, I would like to thank Dr. Fadil. Then will take this lecture and will convert it to videos and share it for others in the Facebook or in YouTube. Good luck for all. See you in the next session. الرحيم. Today I am going to speak about introduction to communication station. This is a simple lecture about the introduction of communication station, and after that in the next lectures and meeting I will speak about the pathway of each cases maybe you will encounter in the exam. Let us first to agree the ethics and the communication station, as the name implies, is designed to test the candid understanding of the core concepts of medical ethics. The ability to discuss about a disease condition and the way the communication is carried out with patient, caregiver or relative or colleagues. You must make sure that the interview is carried out in plain language that easily understandable by non-medical person and to avoid any medical jargon. Communication station, it is very easy to pass and get a clear path in this station, provided that you have taken a time to study the core concepts of communications and ethics. The mistake that candidates commonly make is to read a lot of books without developing any basic understanding of the medical ethics and law. If you are aware of your duties and ethical principles, you should be able to deal with any situation. For this, you don't have to read big books on the subject. Rather, you will be provided with a concise outline of core concepts which should sufficient for most scenarios that are encountered in the examination. First of all, to pass communication station, you have to know the 4 skills in these stations and how your performance have been assessed in the communication station. It is the most important issue to know what is the item you have to cover it in this station, and you have to fill these items during encounter the case in the exam. As we know that we have in this station 4 skills: clinical communication skills, managing the patient concern, clinical judgment, and managing patient welfare. Each skills from these 4 skills has a parameter. You have to cover it clearly, and you have to know what is wrong and what is the right in each skills. First skill, clinical communication skills. What does that mean? First, you have to explain clinical information to the patient. As we said, clear, clear and avoid medical jargon, should be structured and comprehensive in a professional manner. That is mean clinical communication skills. To explain everything for the patient, accurate information and clear information in non-medical term, comprehensive and in professional way. The problem here is the candidate don't give clear information for the patient. This is a problem. Or the candidate use medical jargons. Jargons means that medical terms. or the candidate his way is not professional or unpractical. This is the first skills, clinical communication skills. Second skills here, managing the patient concern. In this skills we have 3 items. Number 1, to answer the patient concern. Number 2, confirm the patient understanding. Number 3, to become sympathy and empathy with the patient. So that in the skills we have 3 items again: to answer the patient concern. Number 2, to be sympathy with the patient. Number 3, to confirm knowledge and understanding of the patient. The problem, if you forget to answer concern, if your way of dealing with the patient is not in sympathy or empathy way, or you forget to check understanding for the patient. Skill number 3, clinical judgment. It means that you have to select proper management plan for the patient, for his case. This is number 1. Number 2, to apply your clinical knowledge, including ethics and law. Clinical judgment has 2 items. First item is to explain the management plan for the patient. Number 2, to apply clinical knowledge, including ethics and law. The problem here, if you forget to apply your clinical and ethical issue, or you didn't explain management plan in proper way. Last skill is managing the patient welfare. It means you have to treat your patient respectfully and sensitively and ensure that the patient is safely and dignity during the discussion, and avoid any physical or emotional discomfort to the patient. So we have 4 skills. Each skills have item, and each items should be complete during the discussion. This is how your performance assessed in communication station. We have common cases in basis, and each case have a pathway different from other case. So in future or in the coming lectures, I will explain the pathway for each item. Common cases here: breaking bad news could be curable or non-curable cancer or chronic progressive disease. Maybe explain new diagnosis for the patient, chronic illness or acute illness. Maybe counseling the patient about chronic illness, about the management plan, dealing with angry patient or relatives, discussion the diagnosis with relative, discussion procedure with patient or relative, DNR, withholding medical treatment, long-term care for patient. This patient is candidate for ventilation or not, and also organ donation. At the same time, we have common case post-mortem examination, hospital post-mortem, or referred to the coroner. Genetic test, one of the famous case in the exam. HIV test, needle stick injury, deliberate self-harm, any medical problem with pregnancy like pulmonary embolism, epilepsy, HOCM, peripartum cardiomyopathy, tuberculosis, thyrotoxicosis and hypothyroidism. Any infectious or notifiable disease like HIV, meningitis, and chickenpox, tuberculosis also. In general, for communication we have some rules and some issue we have to cover it. Each scenario has medical issue to know how is your medical knowledge, to cover it in the clinical judgment, or ethical issue, or legal issues, or social issues related to patient job, or public issues related to other person sharing condition with the patient. At least you have ethical, medical, and legal issues. Sometimes maybe social issues and public issues, and I will mention that in the next slides. What is the ethical issue in communication? We have main ethical issue. First one is called autonomy. What does that mean? Autonomy, you have to respect the patient wishes and decisions. If the patient decides he doesn't agree about your medical treatment and the patient has capacity, we have to agree about that, and we have to respect the patient wishes. If the patient refuses any medical treatment and you feel that it is unwise decision for the patient and this patient has full capacity to take his decision, you have to respect. Autonomy, like consent, like discharge against medical advice and refusal of treatment. That is the right of the patient, provided that this patient has capacity. Number two, doing the best for the patient. Patient best interest. It usually occurs if patient doesn't have capacity and the candidate discuss the patient condition with his relative. Assume that no advance directive. Patient wishes and best interest for the patient, it is one of the most ethical dilemma in the communication station. You are explaining to one relative of the patient his condition. He has subdural hematoma and this patient is candidate now for urgent surgery to evacuate this hematoma. But his relative doesn't like to do for him, doesn't agree about the procedure. But you, as a doctor and your team looking after for patient, the best interest for this patient to do the surgery, and there is no advance directive written by the patient that he doesn't need the surgery. So we have to do the best interest for this patient. Actually, in the exam, it is don't make a confrontation with the patient or relative. Don't make confrontation with relative, and you have to make step by step to explain to him the benefit of the procedure and that the best interest for the patient and it is urgent procedure. So best interest for the patient, it usually occurs if the patient doesn't have capacity and the candidate discuss the patient condition with his relative. Again, assume that there is no advance directive or last power attorney. Number three, avoid the harm of patient even if we are unable to do good. It usually occurs when the relative want to do for the patient something against clinical decision. This is avoid the harm. Sometimes relative want to do for the patient any decision and the medical team looking after for the patient doesn't agree about that. So we have to respect the decision of the medical team. There is a rule that no patient or family doesn't have right to decide what is the management plan for him. for patient or for relative. Patient has the right to refuse the management plan, but doesn't have the right to choose the management plan. Number 4, justice. It means treat all patients equally, also avoid discrimination and abuse. In the exam, maybe you face one patient old age, and the decision this patient is not candidate for resuscitation. And you are going to discuss the condition with the patient, with the relative, and his son or his caregiver told you that, doctor, you take this decision because my father is old, so that your answer should be like that. We have treat all patients equally, there is no any discrimination, and the decision is depend on the guidelines that we are follow it, and these guidelines approved by National Health Service. Number 5, preach your confidentiality, and I will speak in the next lectures about it. And the capacity, you have to decide this patient has capacity or not, and I will explain in the next lectures. Public issue. Some diseases could be affect the public, could be affect other people, so that driving is very, very important. If you face any patient with diabetes, epilepsy, transient ischemic attack, stroke, heart disease, you have to raise the issue of driving. Maybe this bus driver, so that there is a guideline, and there is DVLE guideline according to each case, and like diabetes, epilepsy, there is guidelines. This patient candidate for drive or not, the license should be given to him or not, he has to inform the DVLE or not. These guidelines, all of us have to read it carefully. Infectious and notifiable disease. Notifiable disease means we have to inform National Health Service about it, like meningitis, tuberculosis. It is very important. And also for the patient, some disease could be transmitted to other people, like tuberculosis, isolation or not isolation. I will speak later in the case of tuberculosis about it. HIV, inform a partner or not, it is very important. Meningitis, you have to trace your contact, like TB also you have to trace your contact. Hepatitis B virus and hepatitis C virus, inform his partner or not. Very, very important. This issue is HIV, hepatitis B and hepatitis C. We have to raise the issue of partner and to inform them and to try to convince the patient to inform his partner, and please again don't go in confrontation with the patient. If he doesn't agree to inform his partner at the time being, you have to inform him. At this time, please, you can use a barrier during intimate relationship, and after couple of weeks we can sit again, you will think in this issue, and you imagine that your partner will in the future you have a medical problem, and you hold this information with her. Maybe she will feel frustrated from your decision. So HIV, I will speak later about it in details about confidentiality and who are going to breach the confidentiality. Medico-legal issue. One of the most ethical dilemma also, medico-legal issue, like breaching confidentiality. When you have to breach your confidentiality, patient candidate for resuscitation or not, post-mortem examination, refer to coroner or hospital post-mortem examination, organ donation and donation card, advanced directive and leaving will, withhold treatment for this patient, end of life care asked by relatives called euthanasia. All of this medico-legal aspect. Social issue. Actually, there is no one written that as a separate issue, but I emphasized about it. Why? Because it is one of the most important issue. Always we forget it during discussion. Job. It is very important to ask the patient about his job or relative about the job of the patient. It's a vital if you forget it. Why? Because the job could be the cause of his illness, so that this patient is candidate for compensation. Could be the job is a risk for the patient, like the patient is epilepsy and he is a driver. There is a guideline for that. So that job is one of the most important social issues we have to raise it with the patient. Smoking and alcohol intake. We have to ask the patient about smoking and alcohol intake. Maybe you got in your mind there is no relation to smoking and alcohol, but I will give you an example. If the patient is tuberculosis and you are giving him rifampicin and isolamide, so that this patient is heavy alcohol intake, so that his liver function could be affected by alcohol and the drug. Patient is bronchial asthma, you have to ask about smoking. It's called pre-morbid state for the patient. Marital status or sexual partner. Some scenario that is a vital, like HIV, hepatitis B, hepatitis C. If he is planning to be married, like if you are going to discuss hypothyroidism with the patient, and she is not married now, but maybe planning to be married and get baby in the future, so that you have to tell her that pre-natal care, the patient should her thyroid function normal, and once she gets pregnant she has to increase the dose by 20 to 50 microgram, because her fetus is dependent on the her thyroid. Maybe when you are going to discuss the hypothyroidism you forget this, no relation. Why I will ask her about marital status? Thyrotoxicosis is the same. If you are going to discuss thyrotoxicosis with the patient, very vital. Are you planning to pregnant soon? Why? Propionitracin in the first trimester is candidate for this patient, and carbamazole after that. Who is taking care of the patient? Some scenario you have patient new diagnosed as stroke, and this patient is taking care of his wife, and his wife has rheumatoid arthritis and she has a lot of deformity and she is wheelchair dependent. So you have to tell the patient, ask him in short, not in details, who is taking your care in whom, or if he is taking care of other person in the home. If he is taking the care of other person and he has medical problem interfere with that, we will tell him, I will refer this issue to social worker. She will arrange that for you and she will help you a lot in this issue. Again, social issue, it is a vital. Job, smoking, alcohol intake, pre-morbid state, marital status and sexual partner, who is taking the care of patient, or if the patient is taking care of other person in the home. This ethical issue, medical issue, and public issue, also social issue. We discussed it. Now I'm going to make a pathway. This pathway will be for all cases. To put a plan, also will modify something according to each scenario. Imagine yourself now, you are going to exam. In communication station, you have 5 minutes waiting outside the room, and you have 14 minutes inside the room with the patient, and 1 minute for reflection. How can I arrange my time? 5 minutes before station. Once you sit, they will provide for you paper contains the scenario. If you don't have plan paper, request it from the organizer. Please, doctor, I want plan paper. Read your task carefully in 2 minutes. Read carefully. Read your role and your job and patient name, and read also what is your task. In 2 minutes, you have to decide what is the main medical issue, ethical issue, social issue, legal issue, and public interest. You have to write the patient name. One of the most common mistakes, as we usually do during preparation before exam, we choose 3 to 4 names. Maybe because we usually use it, we forget the actual names that given to us in the during the exam, and you by wrong call the patient by another name. So you have to write the patient name. You have to write your job. What's your job? You are a senior house officer, or you are a registrar. What is your job? You are a medical doctor or cardiology doctor, so that it is very important in discussion with the patient to tell him what is your job. 5 minutes, 2 minutes, read your task. 1 minute, you have to write your job, your name, patient name, and your task. 3 minutes. Remaining 2 minutes in this 5 minutes. You have to divide the paper to 3 parts: introduction, main task, and end of discussion. Actually, during your preparation before exam, do it. It will be habit for you after that, and maybe you don't need to write all of this during exam. Now you are going to discuss the condition with patient, conversation with the patient. Communication is hearing what is not said. Again, communication is hearing what is not said. You have 14 minutes inside the room with the patient. As I told you, we have 3 items: introduction, main task and concern, and end of discussion. Introduction, 1 to 2 minutes to introduce yourself, and we'll speak about the item of this introduction. Main task, concern, 2 minutes, end of discussions, 2 minutes. We have 5 to 6 items in introduction. Four items, it is the same in all. You have to greet the patient according to the time of exam. If you are going to exam in the morning, you tell him good morning. In the evening, you will inform him good evening. Good afternoon in afternoon. Introduce yourself by telling him your name and your role. You have to identify your patient carefully by calling him by his name. Number 4, each meeting or every meeting we have to confirm the agenda of the meeting or interview and take a consent from the patient. It is verbal consent. 4 items, it is the same in all scenarios. if you are speaking to a relative, ask him if he is the next in kin or no. Why? To avoid breach of confidentiality. Actually, if you are going to exam and speak with a relative, be sure that he is the next of kin. But you will have to ask him. Sometimes it is written in the exam paper. Assume that the patient's son has a consent from his father to discuss the condition with you. So that it is written already. If not written, and the patient is conscious, we have to ask him, are you next of kin? Do you have a permission from your father to discuss the condition with me? If he is conscious. But if his father is not conscious and we know not written in the paper that he has a consent from his father to speak with you and his patient is not conscious, just only ask him if it's next of kin or not. If we are going to breed bad news, we have to ask the patient or relative, do you want anyone of your family to attend this meeting or no? So that we have 6 items. These 6 items in introduction we have to cover it. Number 1, greet the patient, introduce yourself, identify the patient, confirm the agenda. If you are speaking to a relative, ask him if he is next of kin or no. Number 6, if we are going to breaking bad news of patient, we have to ask, do you want anyone of your relative to attend this meeting or not? I would give an example now for this introduction. Assume that we have patient has chest pain and already we did for request for him CT pulmonary angio and we found that he has pulmonary embolism. And the patient written in the exam paper, you have to, his son, Mr. Ahmed Ibrahim, he is waiting you to discuss the condition of his father and assume that he has a consent from his father to discuss the condition with you. Let us now begin the introduction. Good morning, Mr. Ahmed Ibrahim. I am Dr. Ahmed now, Senior House Officer in the Emergency Department. Nice to meet you. Nice to meet you, Doctor. Before starting the discussion about your father, I believe that you have a consent from your father to discuss his condition with me. Am I right? Yes, Doctor, you are right. We are going today to discuss the result of imaging that request for your father. Is that okay for you? Yes, Doctor. Do you want anyone of your family to attend this meeting with us? No, Doctor, go on. This is a simple introduction. Good morning. I am Dr. Ahmed, Senior House Officer of Emergency Department. Greet the patient. I introduce myself. Are you Mr. Ahmed Ibrahim, the son of Mr. Ibrahim? Yes, Doctor. This identify your patient. Confirm the agenda. Before confirming the agenda, you have to ask him, I believe that you have a consent from your father to discuss the condition with me. That's right. Yes, Doctor. Confirm the agenda. We are going to discuss the result of the imaging has been done for your father. Is that okay? Yes. It's breaking bad news. So that Doctor, do you want anyone of your family to attend this meeting? This is introduction. In the introduction we have 6 items, we have to cover it. If no breaking bad news, don't offer for him to any relative to attend the meeting with him. If you discuss the condition with patient, so that no need to tell him you have a consent or not, because you are discussing with the patient. This is the introduction. Task. First, don't allow to the patient by his attitude to distract you about the protocol of communication in this part. Sometimes we face angry patient, and once you start the scenario, the patient shouting and he is angry and he distracts you about the pathway. Please don't allow for him to do that. Let the patient to speak and don't interrupt him. You have to listen carefully with non-verbal clue by heading your head, just making a sound, letting the patient speak, like that. It is non-verbal clue and is listening for the patient and one of the communication skills. We have some questions to ask the patient about that. Once you finished your discussion, as usual, in your clinic, if the patient comes to see the result of investigation, or relative come to you to ask about his father or his mother, what is the first question for him? How do you feel now? This is the first question. How do you feel now? You have to start your communication after introduction for the patient. Mr. Ali, how do you feel now? If you are discussing with the relative, please, could you tell me how is your father now? It is very important to make a rapport with the patient. It is a two-way of discussion, this communication. Let the patient to speak and reply to him in sympathy and empathy manner. If the patient told you, doctor, I still feel pain, I have shortness of breath and lost weight, you have to reply, I am sorry for that. It is sympathy and empathy for the patient. You have to make this way in your discussion with the patient. Don't listen only. You have non-verbal clue and the verbal clue. Don't interrupt, but it's just a matter of sympathy. First question, how do you feel now? Second question, how much you know about your illness? It is a very, very important question because the patient will tell him how much he is thinking. Patient has chest pain, when you told him how do you feel now, he mentioned for you I have pain. When you asked him how much you know about your illness, he told you that when I came to emergency room I have this pain, but after that he make a tracing for my heart, like it is ECG, but we are speaking now in a medical term, tracing to my heart, and I feel better. I feel a little bit better. So that first question, how do you feel now? Second one, how much you know about your illness? Third one, do you know why we requested this investigation for you? It is very important to know what is inside the mind of the patient. Last one, what do you expect about the result of investigation? To know also what inside his mind. I expect that doctor, it is a simple chest pain because I have coughed long time ago and traveled abroad, so that maybe some bug, it could be bug inside the chest. He doesn't aware about pulmonary embolism at all, and the diagnosis was pulmonary embolism. So now, before we start the discussion, we have to ask the patient or relative, how do you feel now? Or how does your father feel now? How much you know about your illness? How much you know about your father's illness? Do you know why we requested this investigation for you? Or do you know why we requested this investigation for your father? What do you expect about this, the result of investigation? This is the 4 questions. Sometimes when you go to exam and the patient was diagnosed as tuberculosis and he was isolated in the room, but no one told him why he isolated inside this room. So that when you ask the patient, how do you feel now? He will reply, I still have fever, doctor. I have weight loss and I don't know why you put me inside this room, and all person dealing with me wearing the gloves and no any contact and not allowed for me to go out without mask. No one informed me about that. This patient is angry. Maybe the patient will distract you about this protocol, so that you have to keep calm and reply in sympathy. I'm sorry for that. I will tell you everything. I am here to help you. Then start to ask him to tell the patient, could you tell me how much you know about your illness? He will tell you, I admitted inside the hospital and told me there is bug in the chest, but no one explained to me more about that. I am sorry for that. I will tell you everything about your condition. What do you know why we put you inside this room? No, doctor. Yes. What about your expectation about the result of your problem? I expect to be simple bug in the chest. Then start after that the protocol for each case will speak. So this your start. The first impression for the examiner is this area. Ask the patient, how do you feel now? Let him to speak freely and reply. Ask the patient how much you know about your illness. Ask the patient what do you expect about the result of investigation. Now it's your role. Explain the main task that given to you according to your scenario. And the main task is different in the pathway, so that we'll speak in each task later, but put in your mind you are a leader of the interview, so control the interview through professional manner. Don't rush and speak too much. You have to speak clearly, simple, and put in your mind communication station is two-way of discussion. Don't speak more than 2 minutes without interruption by the patient. If you are going to speak more than 2 minutes and no interruption for the patient, you have to stop yourself and tell the patient, are you with me? Are you following me? Is that clear for you? Or do you want for me to repeat anything for you? To make interruption, to give attention for the examiner, you are not giving a lesson for the patient. It is not a lecture for the patient. It is a two-way discussion. So if your task, sometimes some tasks need more speaking and the patient is listening to you 3 minutes, 4 minutes, 5 minutes. It is not communication. It is a lesson for the patient. So that after 2 minutes, stop yourself, tell the patient, are you with me? Are you following me? Any question, sometimes also ask me, is that clear for you? Do you want for me to repeat anything? To make interruption. Yourself. Again, check communication and the medical and the legal and the ethical issue to discuss here. After finish the main task, patient could be ask you some questions. Okay, no problem. We'll discuss this later. You have to ask about the concern direct question. Do you have any concern? It is a direct question. Do you have any concern? Actually, the patient has paper written 2 or 3 questions. When you underwritten that concern and written 1 or 2 questions, so that the patient will tell you his concern. Please again, don't forget this. Once the patient asked you or tell you the concern, you have to answer it. And answer of the concern, it is vital. Because some candidate it is escaping from the answer. When the patient asks you, doctor, this disease is curable or not? Some candidate tell, it could be curable, it could be non-curable. No, you have to give you answer according to your clinical knowledge and information. If the cancer and the metastasis, you tell him, I am sorry to inform you that this disease, it is not in the lung only, it is spread also to other organ and no surgery for this disease. I am sorry to inform you, it is only palliative treatment. That is meaning control your symptoms, so that your answer should be clearly and your answer should be accurate. Again, once you asked about concern, after finish the main task, you have to answer the concern. Concern is the most important skill in the exam. Why? We have concern in station 2 in history, station 4 communication, and 2 cases in the station 5. Concern is about 16 marks. 16 marks. In each station 4 marks. 4 marks in history, 4 in communication, 4 in the first case of clinical, first case in station 5, and second case in station 5 also 4 marks. If you lost 2 concern or 2 stations concern, you will not pass the exam. So concern is a most important skill. You have to manage it in the right way and to answer it clearly. Now, we mentioned introduction, main task, concern, then end of discussion. End of discussion, it is very, very important because a lot of candidates fall with it. And during our lecture today, I mentioned that check understanding in the manage patient concern skill. It is written in the mark sheet. End of discussion. Number 1. We have to summarize the discussion and emphasize about important notes by saying to the patient, I will summarize now the important note in this discussion. Don't give more time for summary, just to highlight the important note. Don't repeat the discussion again. You are in this area, we are going to tell the examiner about that we make summary, not more than this. So that you take only some few seconds, not more than 30 seconds. I'm going to summarize for you most important issue today. You were admitted to the hospital by chest pain, and we make tracing of your heart and imaging in your lung, and I'm sure to say to you, we found that blood clot inside the blood conduit of your lung, and as I told you, we will admit you to the hospital and we will give you medication. This medication will make thinning of the blood and will admit you until you reach your blood thinning to the therapeutic range, and we will discharge you after that and follow up in outpatient clinic regularly. This is the summary, not more than this. Second, we'll tell the patient, I appreciate we have covered a lot of issue today. Is there anything you would like from me to repeat it again or to go over again? The patient will reply, no, actually. Check understanding is very important. You will tell the patient, I hope our discussion is useful for you. Can you tell me how much you get information from me? The patient will tell you about the issue he want or issue he understood it during the discussion. So that it is very, very important to check understanding for the patient. Number 4, help. You have to offer help to the patient, like these websites and leaflet, brochure and videos about your condition, about pulmonary embolism. You have to read it, and if you have any question or any inquiries about your problem, this is my contact number. You can contact me at any time. It is a help. Again, this is a standard. Each case we have to do that. Each case. But in case of this, don't mention the patient, I will give you a website or brochure about this. It is not practical. Okay? Or number 4, help. Number 5, we'll tell the patient, I hope you have found our discussion useful to you. Do you have any further question or concern? It is one of the important question here. I hope you have found our discussion useful to you. Do you have any further question or concern? Maybe sometimes there is a hidden concern you didn't discuss and the patient wait to repeat it again for him. So that it is very important to ask and repeat again for the patient. Do you have another concern? Then thank you for the patient and shake hand. So, end of discussion, we have 6 items. Number 1, summarize. Number 2, ask the patient if you want anything to repeat it for him again. Number 3, it is check understanding. Number 4, help. Number 5, do you have any other concern? Number 6, thanks and shake hands with the patient. Now we reach to end of scenario during exam or your preparation. What can I do during 1 minute for reflection? So that we will wait 1 minute before discussion with examiner or your colleague during the preparation. Don't consume this minute in blaming yourself if you missed an item, but put in your mind it is overall satisfaction. One item will not affect you at all. Don't blame yourself if you forget an item during discussion with the patient. It is overall satisfaction. You have to make rapid interpretation of your case and emphasize again about ethical, legal, medical, social and public issue as I mentioned before. Be sure, all questions with the examiner you already faced it during the preparation in our course, so that feel confident at all. We did a lot of cases during the preparation and it is repeated cases. So be sure all questions he will ask you medical items about your case or some ethical and legal issue. Be sure and be confident you will answer this question inshallah. So that make proper plan and the proper practice will make all this stage too simple. As I mentioned before in my introduction, you will do it but your subconscious mind. So that is don't feel that it's too hard. It's too simple. If you do it regularly, it will be a habit. Please again do it simply and your way of preparation will determine your way of pass of the exam. Feel confident about your preparation and your exam will go simply and no need for hesitation. Again, this is a simple preparation for communication, and also I would like to say in the next presentation or lecture I will speak about each case separately. We have now introduction, it is the same. End of discussion, it is the same. First part of the new task, it is the same. So in this meeting or in this lecture, about 40% of communication of skills we discussed it. In next lecture I will speak in details about how to break bad news, how to handle aggravation, how to go through the explanation of chronic illness, how to explain the procedure, what is the criteria of consent, and what is the criteria of post-mortem examination. I hope all of this will be simple for our candidate, and see you in speak about it soon. And again, thanks for Dr. Khatib about his effort, and see you inshallah in the future. Thank you. Bismillahirrahmanirrahim. This is the third lecture in our course for serious videos of communication. First of all, I apologize about the voice today because I have sore throat. Today I am going to discuss decision. who is responsible about health decision? Is this for the team? Is this for doctor or relative? Our lecture today, who will take the decision and who is responsible to apply this decision. These rules for health decision, it is under control of Mental Capacity Act, and each person in the medical decision pathway has a responsibility, and each one should know which his responsibility. What is the Mental Capacity Act in the basis exam? Mental Capacity Act, this rule is made to apply it during discussion with patient or during discussion with relative, or if there is no relative or no anyone appointed to take the decision on behalf of patient. This is called health decision. Is this doctor or nurse or care provider or medical director who is responsible about health decision? Before we speak about the health decision, I would like to say, in communication station we have to think about each words we are going to tell the patient or examiner about it. So, before you speak, your words have to pass through 3 gates. At first gate, ask yourself, is this information true or not? Is it true? At the second gate, you have to ask, is it necessary? At the third gate, you have to ask, is it kind? We are here to check the 3 gates. Our information, is it true information or not? And is it necessary to discuss it or not? That's according to your task. Don't imagine another task. And don't say something you didn't request, you didn't see it in your task. Third one, is it kind or not? Because we in communication station, we have to keep the patient most of the time quiet and they didn't affect him physically or psychologically. So that before you speak again, you have 3 gates, each word have to pass through 3 gates. As I mentioned before in introduction, it will be about your subconscious mind. So from now, before you attend your exam, you have to make rehearsal for your subconscious mind. Again, if you have knowledge, you will speak well. But the wisdom to listen well also to the patient. Again, if you have knowledge, you will speak well. And the wisdom to listen to the patient carefully. As we are going today to speak about consent and who will take the consent, put in your mind, no one can make you feel inferior without your consent. So in the exam, you have to be confident. No one can make you feel inferior without you have consent. And your silence is one of this consent. But in our practice, silence of the patient doesn't mean this is consent. The consent should be written, but there is verbal consent for examination or starting scenario, as I said in the introduction. The most problem in communication or in exam, you feel you are inferior to examiner. Put in your mind this information. You have a lot of knowledge and you have a lot of information, maybe more than the examiner. But the problem is you give a consent, you are inferior to them. So you have to make yourself self-satisfied and you are superior to others. There is a problem in communication. Communication station, sometimes there is illusions and hallucination coming to the candidate. He imagines something written in the scenario. He imagined that he did this information and he said to the patient some information. Again, avoid illusion and hallucination. After this small introduction about the consent and about the gates that we have to pass through it for each word before you speak it, and about the consent, let us to start with consent. Consent means two types. There is verbal consent and written consent. Verbal consent, before you examine the patient, Mr. Muhammad, could I examine you? Mr. Muhammad, could we discuss together your case? This is verbal consent. But written consent, it should be for all procedure. Please put this inside circle. Okay? Each procedure have consent. We have two blood tests need consent, genetic test and HIV. All procedure need consent. Genetic test and HIV need also consent. All other blood tests no need consent. How can I sure this consent is valid? Validity of the consent. How can you sure after you married this paper contract between you and your wife is valid? So consent should be informed one. What is mean by informed? Informed means you told the patient about everything about the procedure, even if it is minor complication could be happened. And the patient tried to know everything about the procedure. Number two, the patient should be competent and have capacity to make decision. The patient should be competent and have capacity to make decision. That is mean the patient should be conscious, alert, and can understand the information and outweigh the benefit and the risk of procedure, and we can give you decision. That is mean capacity. Number one, informed. Number two, capacity. Number three, the patient should be volunteer. No pressure for the patient, no pressure given to the patient from the doctor or family to do this procedure. The patient should be volunteer. Number four, continuity of the consent. Means that the patient has the right to withdraw consent before the procedure done. I will not delay, doctor. I will not delay here. This continuity of consent. If you have a consent, you have to cover this four area. I said before in many lectures about consent, and I give an example for that with paragraph. I will say it again and again, and I will tell you have patient now is candidate for liver biopsy. And after you explained for him everything, now you have to tell him to sign a consent. This paragraph, keep it in your mind. Mr. Ali, I explained for you now the procedure of liver biopsy, and I mentioned for you everything about it. I also informed you about the possible complication could be happened. First of all, Mr. Ali, feel free to agree to do this procedure or not. That is your right, and that is your right to do this procedure. Also, I will submit for you paper. This paper contains the name of the procedure and what is the benefit and the risk of this procedure. And also the complication could be happened during the procedure. You have to read it carefully, and if you have any comment or inquiries about anything related to the procedure, you can contact me. After that, you have to sign the consent before the procedure. And I want to assure you, even if you sign the consent and you want to withdraw this consent before the procedure, that is your right. Feel free to do that. What do you think about that, Mr. Hari? Simple way, this is the consent given to the patient. Now, I am going to explain what is the pathway of consent. We have many patients. Patient has capacity, patient unconscious, patient has advanced directive or living will, patient has last power attorney, patient alone and he is unconscious. So, let's start to check this pathway. Keep please your mind with me and give me all your attention and concentrate well in this slide. This slide contains a lot of information about the Mental Health Act, and it's a summary of most of scenarios that you may be encounter it in exam. First, is this patient has capacity or not? This is the first question. Is this patient has capacity or not? Okay. Yes, this patient has capacity. What does the capacity mean? If you look to other left part of the slide, you will find the criteria of capacity. Criteria of capacity is the patient has to understand the information and retain this information and outweigh the benefit and the risk of information. Then he can communicate this information. These four criteria for capacity. Again, repeated again. And the repeated information always for pioneer people. You have to understand information, retain information, outweigh the benefit and the risk, and communicate this information and decision. If it has capacity, the decision for the patient. The site type, okay. If the patient doesn't have capacity, what is the next? I will ask if this patient has advanced directive or living will or not. case, if the patient has advanced directive and leaving well, we will follow it. And this advanced directive is valid. Again, capacity or not. Has capacity, يبقى the decision for the patient. No capacity, I will check advanced directive. If he has advanced directive, we will follow it. If no advanced directive, I will ask about last power attorney. If the patient has last power attorney and it is valid, I will explain later what's mean by last power attorney and what is advanced directive in detail in this lecture. If the patient has last power attorney and this last power attorney mentioned in his registration, he can take decision on behalf of patient. Even in the serious condition, we can follow last power attorney. If no last power attorney, we will do best interest for the patient. I explained in the introduction what is meant by best interest for the patient, and I will repeat it again. Best interest, if the patient doesn't have capacity, we will do the best thing for the patient. Okay. But we have now two pathways. Capacity, the decision for the patient. No capacity, we have three pathways. Has advanced directive, we'll follow it. Last power attorney, we'll follow it. Has no advanced directive or last power attorney, will do the best interest for the patient. I will speak later about the independent mental capacity advocate and what that means. But we have to put this in our mind now. The patient has capacity or not? Has capacity, again, his decision. What is mean by his decision, please? Yes. The decision, he's agree about the decision of the medical team. But the patient or relative doesn't have right to request any medical treatment. This rule, the patient or relative doesn't have right to request any medical treatment. If no advanced directive, we will check last power attorney and patient wishes. I will give an example in this issue. Now I am discussing the case with a relative. I am discussing about big tube insertion. Now I will tell the relative, after I explain to him what is the benefit and risk of the procedure. Mr. Ali, could you tell me if your father had an advanced directive or leaving will? No, doctor, he doesn't have any. Your father appointed anyone to take a decision on behalf of him when he lost his capacity? No. No, doctor, he doesn't appoint anyone. Mr. Ali, could I ask you about the wishes of your father if his condition become like that? I mean, he expressed for you about his wishes when he lost capacity? No, doctor. So I asked about three parties, about advanced directive, last power attorney, and patient wishes. This is dealing with unconscious patient. Now, after that, we'll go in details and deeps more and more inside the Mental Capacity Act. Sorry. First, what is the summary of decision making? First, assess capacity. After that, best interest, advanced directive, last power attorney, discussion with relative and caregiver. In independent mental capacity advocate, court-appointed deputy, court of protection, application to the court. What's that? Oh my god. It's very hard. It is very hard. It is very easy. Don't assume that it is very hard. Dr. Ahmed said, I think 3 hours ago, it is anti-headache. So, please keep silent and have a sip and take a cup of coffee and concentrate with me. This is the summary of decision making: assessing the capacity, best interest, valid advanced directive, valid last power of attorney, discussion with relative and caregiver, independent mental capacity advocate, court appointed deputy, court of protection, application to the court. By the way, all these lectures that I am going to do all content, it was the content of my book for communication. Let us my first one as introduction of this lecture about the capacity. Mental Capacity Act, it is mean the ability to make a decision. A person lack capacity when they are unable to make a decision when the decision needs to be made. The ability to make decision may be affected by a number of conditions like stroke, dementia, head injury, learning disability, and severe mental illness. Patients may lack capacity temporarily only, like acute illness or alcohol intoxication, or may be in accident. This capacity could be also permanent. The summary of these slides: Mental Capacity Act, who will take the decision when the patient lost capacity. This is the summary of this slide. And also, the capacity could be lost temporarily or permanent. If you have a basic understanding of the Mental Capacity Act, you should be able to deal with any ethical dilemma around it without any difficulty. As we said now, you have to know everything about the Mental Capacity Act. And if you know that, you should be able to deal with any ethical dilemma around it without any difficulty. You will sit in the exam and speak very confident and in ease by your subconscious mind. In the exam scenario, you may be given situation which will require some form of decision making on behalf of patient who lack capacity. Here you are unsure if the patient has capacity to decide for the treatment or involving the family member in the decision making process. The situation that may arise are consent for a procedure or urgent treatment or withholding the treatment and acting in patient's best interest. We have 5 core principles of this Mental Capacity Act. We have 5 cores. We can say 5 fingers. Okay. Person must be assumed to have capacity unless established otherwise. And each person have capacity until proved otherwise. By other means that you are a doctor until proved otherwise. Number 2, each person should be helped to make his own decision. No pressure. feel free to do that. Number 3, a person is not to be treated as unable to make a decision merely because he makes unwise decision. There is justice. I told you before, maybe patient refuse to do liver biopsy, so that don't tell him, no, I will not treat you. You take unwise decision. You have to treat him. By other way, if you admitted the patient for infective endocarditis and this patient wants to charge against medical advice, he has to discharge against medical advice. If she needs that, don't tell her, I will not write for you medication because you go home against medical advice. This is the explanation of third principles. Any decision and action must be in the best interest of the person lacking capacity. If you have patient lacking capacity, should be in the best interest. What do you mean by best interest? Means that is something good for the patient. All decisions and action must be the least restrictive of the person's right and freedom of action. Means again, all decision and action must be the least restrictive of the person's right and freedom of action. All 5 are equal. These 5 principles are equal. To explain more and emphasize about the Mental Capacity Act, it is very important Mental Capacity Act to understand it. It is one of the vital area in the communication. Every adult has the right to make his or her own decision. We have to be equal, his or her. Every adult has the right to make his or her own decision and to be assumed to have capacity until provided otherwise. Again, every adult has the right to make his or her own decision and to be assumed to have capacity unless proved otherwise. Everyone should be encouraged and enabled to make his or her own decision. Individuals have the right to make unwise decision. I have now one patient has hematemesis and his hemoglobin is 6 and he refused blood transfusion. Yes, it's unwise decision, but he has the right. If he has capacity, he has the right to refuse any procedure. For capacity, we have 4 criteria for capacity: understanding information, retaining information, outweigh the benefit and risk of the procedure, communicate his decision. Look for this photo. You will find doctor and the nurse fighting together in front of the patient, and the patient is opening and closing his eyes. He feels frustrated so that he can't understand any information. So capacity, understanding information, retaining information, outweigh the benefit and the risk of the procedure, and communicate his decision. Maybe the examiner asks you in the exam, what is the criteria of capacity? We have this criteria. If this patient have 2 stages, if the patient is there in impairment or distribution to the function of the brain or mind, is the impairment or this distribution sufficient that the person is unable to make the practical decision? Actually, in the exam, they will not give you the patient without capacity. All patient has the capacity inside them. But maybe this for examiner could ask you any question, so that we are ready for any question. Person with duty of care must assess capacity to make a practical decision at the time the decision needs to be made, and shouldn't assume that person can't make any decision. Person's loss of capacity may be temporary only, as I said, and the capacity could be fluctuating. Some people may lack capacity to make complex decisions, but retain the capacity to make other decisions, like demented patient. What mean by incapacity? Incapacity could be temporary or permanent, decided on balance of probability. Avoid making capacity assumption on the ground of age, appearance, condition or behavior, because one patient age may be 16 and he has capacity to make his decision. Next one, advanced care planning, ACP. Advanced care planning. I think you finished half of your tea or coffee, and give attention again for me for advanced care planning. Take the breath and listen to me. Advanced care planning, it is a continuous process of discussion between an individual and his care provider. Again, it is a continuous process of discussion between person and his care provider. Advanced care plan discussion may include individual concern, important values or person goals for care, his understanding about their illness and prognosis, what is the benefit for patient in the future and the availability of this benefit. Mental Capacity Act requirement to take account of these value, wishes of patient will assess best interest for the patient. These views must be taken into account of the caregiver. Advanced care planning, it is a continuous process of discussion between an individual and his care provider. Mental Capacity Act requiring to take account of the patient's value, wishes and his expressed of his wishes or not. So that when I speak and I told you about the pathway of consent, I mentioned capacity and incapacity. Incapacity 3, number 1, advanced directed and leading will. Last bar Atme, number 2, number 3, patient wishes, advanced care planning. Best interest decision. A person doesn't have mental capacity to make a certain decision. Any decision made in their behalf by anyone must always be in the best interest for the patient. Anyone will take the decision on behalf of the patient should be in the best interest. Again, concentrate. Don't go away. Keep your mind with me. A person only has legal authority to make a decision on behalf of person if they are an attorney. Now, the decision on behalf of the patient, last bar attorney or court-appointed deputy, or if they have been given specific permission to do so by the court of protection. What is this difficult word? It seems so hard. No, it's too easy. Again, who will take the decision on behalf of patient? Last bar attorney, and I will speak now about it. Court-appointed deputy, it is one appointed by the court, or permission by court of protection to someone to take the decision. However, informal decisions are made all time by those surrounding a person without capacity. But they must always be in the person's best interest. Who will decide the person's best interest? It is the person's wishes and values. Best interest decision must take into account certain factors. I'm speaking a lot about the best interest because in the exam, if the patient doesn't have advanced directive for leaving the will, we are going to speak about the best interest and the patient wishes and values. We have to see all relevant circumstances. This decision can be put off until the person has regained the capacity if it's possible. I mean that we have patient now alcoholic. Actually, this is not in the exam. Alcoholic, and he doesn't have capacity, and you want to do for him cholecystectomy. You have to wait. He comes with abdominal pain, and you find that he has cholecystitis. It is not urgent, so that we can wait and postpone the decision. Maybe the person will participate in the decision, like alcoholic patient. The person wishes, feelings, beliefs, and values, especially if they were written down before they lost capacity. One patient wrote that, I don't like to be resuscitated, and it already signed and stamped and dated, and there is witness. We have to follow this one, this advanced directive. Best interest for the patient, we have to take the wishes of the patient from his surrounding, family, friends, caregiver, that appointed to act on behalf of the person. We have to be least restrictive of freedom. Is there any conflict evidence between you and the patient relative? Always provide clear and objective reason for the decision and why you believe it is a person's best interest. Again, best interest for the patient. It is your duty to consult other people when working out best interest for the person who lacks capacity. The following people could be helpful for you. Now we mentioned and explained best interest. In summary, 2 words only. Best interest for the patient, don't do harm for the patient. If the patient doesn't have capacity and no advanced directive for leaving will, and at the same time no last power attorney, we will check his values and belief with relative or caregiver, and we will put in our mind this value and belief, if it is the best interest or not. advanced directive at the leaving while. This is a contract. Advanced statement affect the way people make decisions about their future care if they lose mental capacity. This includes decisions on whether they want life-saving treatment and participate in research. Advanced decisions can't be used to refuse basic care, including warmth, shelter, hygiene, oral food, and water, but not artificial nutrition and hydration. I think you have some coffee in your tea, some coffee in your cup, so that take the breath. Advanced directive, something written by the patient when he has capacity, and we use it when he lost his capacity. And everything written in this paper, we have to follow it. The patient has the right to do that, but it's not the right of the patient to write, I don't want to do ill hygiene. It's not his right. How can I know this advanced directive is valid or not? How can I know that? Validity of advanced directive. Each advanced directive should be full details of patient, name and address of GP, and whether the GP has a copy of it or not, capacity, the patient has capacity, the patient is volunteer, and informed means patient knows the implication of the choice in his life. And this advanced directive should be clear statement of the decision and should be specify the treatment to be refused and which circumstances the decision should be used or which will trigger a particular course of action. Oh my god, what's this? Blah 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 blah. No. The advanced directive should be clear. Decision written inside it. Specify the treatment. Why he refuses, specify the treatment to be refused. And also when we use this circumstance, when we use this advanced directive, should be dated and time and documented. The patient has to be sign of the person, sign of witness. To know the validity of advanced directive, first we have four items. The patient should be have capacity and volunteer, like consent, should be informed. Informed means implication of the choice in his life, and should be clear statement. What is the treatment he refused? What are the treatment he refused? He should write, I refuse to take any blood transfusion if I need it. So that we will not give him blood transfusion if he lost capacity. I refuse to be resuscitated if my heart stops, so that we will not do CPR for him. But if he has COPD and he needs mechanical ventilation, we will do for him mechanical ventilation, because mechanical ventilation is different than CPR. He doesn't write in his advanced directive, he doesn't need any mechanical ventilation. So should be clear statement specified, and for any paper we use it should be dated, time, signature, and witness. This is the criteria of validity of advanced directive. There should be patient volunteer, capacity, informed, clear information about his decision, and specify the treatment to be refused and which circumstances in which the decision should be used. Should be dated and signature and signed, and also signed of witness. When advanced statement can can it be overridden? We will not use it. Concentrate again. Take shallow breathing, not deep breath. Finish the shallow breathing? Yes. خلاص okay. When this advanced directive, we'll neglect it, we'll not look for it. A validity signed last bar attorney for welfare signed after the advanced decision can override it, especially if it gives the attorney the right to consent or refuse life-sustaining treatment. When we can neglect this advanced directive, if the patient wrote advanced directive and he has capacity and it is valid, after that 3 to 4 months he wrote he appointed last bar attorney. So the recent one will take it. If he wrote last bar attorney after advanced directive, so the last bar attorney will be the valid. Specify also what the last bar attorney will take the decision on behalf of him. If it is not clear what is the treatment or what is the circumstances the person want to take it, you can neglect it. There are 2 causes to neglect this advanced directive. Override a decision made by a person who has got capacity. Refuse basing the nursing care to keep the person comfortable. Refuse food or drinking by the mouth. All of this should be refused. And we will neglect that advanced directive. We will neglect if recent last bar attorney or it's unclear or the patient wrote refusing basic nursing care, we will not follow this one, or refusing food or something by mouth, we will not follow it. Demand treatment which medical professionals feel is inappropriate. If the patient wrote in advanced directive on leaving will, he lost capacity, please doctor give me concentrated electrolyte and kill me. We will not follow it. Refuse treatment for a mental disorder if the person is or is liable to be detained under the Mental Health Act. Again, it's very important. Maybe the patient has some psychiatric problem. He doesn't have the right to refuse treatment. Ask for anything against law, such as euthanasia, to kill himself. Because it is important to give this document right for it to take effect when the person wants. It should normally be drawn up by a lawyer solicitors. When we neglect the advanced directive, again, if we appoint recently last bar attorney, if it is not clear, maybe refusing the nursing care, refusing food, demand treatment not appropriate, and refuse treatment of mental disorder, anything against law. This is the advanced statement or advanced directive or leaving will. 3 are the same. I know that this lecture is too long lecture, so that I want from everyone to make another cup of coffee and enjoy when we are discussing this Mental Health Act. We discussed advanced directive or advanced statement. The next one in the Mental Health Act, we will go through last power attorney. Last power of attorney is a legal document that lets the person to appoint people known as attorney to make decision on his behalf or on your behalf. It could be used if you become unable to make your own decision. But this last power attorney, it is the same as advanced directive. But in advanced directive, the patient wrote what is about his decision when he lost his capacity. But here, in last power attorney, the patient mentioned that and he appointed one person to take a decision on behalf of him when he lost capacity or when he become unable to take decision. This is last power attorney. Last power attorney, it allows you means patient, to choose one person or more to make decision about things like your daily routine, your medical care, moving into a care home, life sustaining treatment. So the patient has to specify about the point that last power attorney will take the decision on behalf of him. Again, the patient has to specify about the point which the last power attorney will take decision on behalf of him. That's clear. If he mentioned to take of medical care, that's okay, but he didn't mention life-sustaining treatment, so that the last power attorney doesn't have the right to take decision in life-sustaining treatment. We will follow what's written in the paper of last power attorney. This type of last power of attorney can only be used when you are unable to make your own decision. Here, this instruction to the patient. The type of last power attorney can only be used when the patient is unable to make his own decision. Who can be your attorney for the patient? Attorney could be anyone, any person above 18 years, could be relative, could be friend, could be a professional, could be your husband, your wife, or your partner. Validity of last power attorney. When we can say last power attorney is valid to make decision. Validity of last power attorney, person and the last power attorney both have capacity when he appointed last power attorney. The patient and the last power attorney, both of them have capacity. And we defined already what's meant by capacity. Person is the patient and the last power attorney both above 18 years old. Should specified as anything should be specified what is the role of last power attorney in his to take decision on behalf of patient. Anything written should be signed and dated by both last power attorney and the patient, and to be documented or registered. That last power attorney must be registered with the Office of Public Guardian before it can be used. The validity of last power attorney, both above 18, both have capacity, should be specified, signed, dated, and registered. Everything should be signed, dated, and registered. Same like advanced directive and or leading one. When the attorney can't consent in this situation, the doctor want one to take decision, and he has attorney. When this attorney, we can't follow him. The donor has capacity to make the particular healthcare decision. يبقى the patient has capacity. If the patient has capacity, the decision for the patient, not for last bar attorney. Last bar attorney only if the patient lost capacity. The patient he already done or wrote advanced decision or advanced directive to refuse the proposed treatment after he appointed last bar attorney. What does that mean? He wrote already last bar attorney, and after a couple of months he made an advanced directive. So advanced directive will remove this last bar attorney because it is recent. If the decision related to life-sustaining treatment, except when making the last power attorney, the donor has specified state in the last power attorney document that they want the attorney to have this authority. If we are facing life-sustained treatment, and if the patient doesn't mention in the last bar attorney document about life-sustained treatment, we will not follow the last bar attorney. But if he mentioned this last bar attorney person, he can take a decision on behalf of him, we will follow that. If the patient under the care of Mental Health Act, Mental Health Act, it is no way. What is mean by no way? No decision for the patient or for last bar attorney. The decision for the doctor only, for doctors only. If the attorney can consent, if he lost it, if the patient has capacity, if he has recent advanced directive, if doesn't mention in the last bar attorney document about the life-sustained treatment, if the patient under care of Mental Health Act. I will summarize again. If the patient has capacity, he will take the decision. If the patient doesn't have capacity, we will follow number one, advanced directive on last bar attorney, which is recent one, or will take the best interest for the patient. This is a summary of all this 57 minutes. We'll go now to other issue. It is called independent mental capacity advocate. Mental Capacity Act in 2005 create independent mental capacity advocate service as safeguard for people without capacity to make certain important decisions. In 2005, they appointment and they create a new job. It's called Independent Mental Capacity Advocate, or IMCA, we can say it. What is the role of IMCA? The role of IMCA, an IMCA must be instructed and then consulted for people lacking capacity. But number one, the patient should be lack capacity, who have no one else to support them. The patient has capacity, lost capacity, and no one to support patient. If we are going to give serious medical treatment, we will consult this IMCA to inform him about the patient condition and explain to him what is the role of treatment and what is the benefit of treatment. If we are going to arrange home care for patient, and the patient no one can take his own decision and he already lost capacity, so we'll consult IMCA. If the person will stay in the hospital more than 28 days, if the patient will stay in the care home for more than 8 weeks. Again, role of IMCA INICA, if we are going to make a serious medical treatment if the patient doesn't have capacity and no one to support him, we will consult INICA. If we are going to transfer the patient to home care and no one to support him, what is mean by no one support him? No relative, no anyone, no caregiver. Person will stay in the hospital more than 28 days. Person will stay in the home care more than 8 weeks. This INICA, this one person already, have the right to request a second medical opinion in relation to the treatment decision. Actually, in the exam, what is the role of INICA in your communication skill exam? INICA will look over him because you are always discuss the case with the patient or with the relative, and the patient, he can take his own decision, and the relative, it is one of support to the patient. But the examiner could ask you if this patient doesn't have capacity and this patient can take his own decision and no one to support him, how can you proceed for the treatment for this patient? And you are going now to do for him this chest tube, but it's not urgent. If the chest tube is urgent, we have to proceed. But if it's not urgent, you can tell him you consult the INICA, Independent Mental Capacity Advocate. So it is not too much coming in the exam, but to keep in your mind, if one of the examiner discussed with you this issue, you have to put in your mind INICA. Court. Now we're going to the court. Oh my God. Court appointed deputy. This person, one person who is appointed by the court of protection to make decision on the health care, person welfare or financial problem on behalf of patient. Essentially, it is a similar authority of last power attorney, except that they didn't have the power to refuse life-sustaining treatment. This is the summary. Last power attorney, it is appointed by the patient when he has capacity. Court appointed deputy. The court appointed one person to take the decision on behalf of patient. The same last power attorney, except that they don't have the power to refuse life-sustaining treatment. Also, in the exam, it could be discussion only with the examiner. Do you know what I mean by court-appointed deputy? Yes, I know. And we would be excellent in our answer if we said it is appointed by the court of protection to make decision on behalf of patient in the form of health problem or welfare and financial issue. It is the same like last power attorney, but court appointed deputy doesn't have the power to refuse life-sustaining treatment. And we said already, last power attorney has the power to refuse life-sustaining treatment if it is mentioned in the last power attorney document. But if it doesn't mention, he doesn't have room to refuse life-sustaining treatment. That's about last power attorney. Who can be a deputy? Court of protection will be appointed one. Who is this one? Deputy is usually a close friend or relative or person who need help to make decision. Maybe this deputy could be professional like accountant or solicitor. Local authority are often appointed as a deputy. Anyone can be appointed as a deputy according to the court. What is the responsibility of deputies? Or what is the type of deputies? Deputies we have two types. One will look for financial affairs and one will look for health problem and welfare. Maybe more than one person appointed as deputy to each type. Maybe the court will appoint one for health care and one for financial affairs, or one for both. the responsibility of appointed deputy. The court of protection will tell the deputy about his power and responsibilities, what decision they can and can't make. Deputies must only make decision in other person's best interest. Again, the deputy should make a decision in other person's best interest. Only make the decision the court says they can make. Apply a high standard of care when making the decision. The deputies must be only make decision on the best interest for patient and make decision that the court says he can do it, and also should be high standard of care. These deputies that appointed by the court, he can't take decision to restrain the person unless it is stop them to coming to harm. He can't take decision about life-sustaining medical treatment. He can't make a will for person. He can't make large gifts out of the person money. Hold any money or property in their own name on the person's behalf. For ourselves, to avoid confusion, this duties for us doesn't have the rule to stop sustained medical treatment or restrain the person. This two rule. Others is related to financial affair, so that restraining person and stop life-sustaining medical treatment doesn't have rule at all in the court-appointed deputy. Or court. We know now IMCA, Independent Mental Capacity Advocate. We know court-appointed deputy and what's his rule. And the rule, it is the same. We can say it is the same like last bar attorney, but without life-sustained medical treatment. He can't take decision. And now we'll go to court of protection. The court of protection, it will decide whether a person has capacity to make a particular decision for themselves. Decide this person has capacity or not. Make declarations, decisions, or order on financial or health care matter affecting people who lack capacity to make such decision. Appointed deputies to make decision for people lacking capacity. Decide whether an last power attorney is valid or not. Remove deputies or attorneys who fail to carry out their duties. Again, court of protection, it is the final issue. It will decide this person has capacity or not. Maybe court of protection will take decision on behalf of patient, and if the patient lack capacity, it could be appointed anyone to make decision for people lacking capacity, and when there is confusion between doctor and the last bar attorney, they can decide. Remove deputies or attorneys who fail to carry out their duties. In the exam, how can you handle this? The examiner could ask you, if this patient lack capacity and no one support him, I will tell him you can go to IMCA or go to the court of protection, and IMCA will know the rule, and the court of protection could be appointed one to take a decision on behalf of patient other than life-sustained treatment, or this court of protection itself could be take a decision. This is the answer. But if we have patient lacking capacity, we can go IMCA or go to the court. Court could be appointed anyone to take a decision on behalf of patient except life-sustaining treatment, or the court itself could be take a decision. If we have a conflict between us and last bar attorney, that we can go to court of protection. But please, again, it is not coming a case in exam. And I mean that in the exam, they will not give you when you have last bar attorney, and this last bar attorney refuse medical treatment that could be help the patient. Actually, last bar attorney will work in the best interest for the patient, but in the exam you will not face any confrontation between you and the last bar attorney. We didn't see it in the exam. This is the last one. We have now 3 ways, as I said in summary again, 3 ways. We have patient has capacity, he has decision, no capacity for the patient, so that the patient will go through advanced directive. If no, will go last bar attorney. If no, nothing like that, will go to the patient wishes. If no, will go to best interest for the patient. This is the pathway of consent. Other than this, we can go to UNICA, and we now know the role of UNICA, and also will go through the court of protection, or appointed by the court, and we know what is the role of court appointed deputy that appointed by court of protection, and the role of court of protection. For example, some capacity cases which should still go to court. If we are going for organ or bone marrow donation by person lacking capacity to consent. One person has pre-existing and lack capacity, and he doesn't have any advanced directive or donor card, and no one to support him, so that we can go to the court to take. The court will take a decision if we can proceed for organ donation or not. If the person for organ donation again should go to the court when if this patient has lack capacity, number 1. Number 2, no donor card or advanced directive that he want to donate his organ. Number 3, no next of kin or no one support him. If we have patient in persistent vegetative state, for withdrawal or withhold treatment, we have to go to the court. Non-therapeutic sterilization, some termination of pregnancy case, and we have a lecture about abortion. We will see it in the coming days. Cases where we are doubt or dispute about whether a particular treatment will be in a person's best interest. Cases involving ethical dilemma in untested area. Just only for theoretical knowledge, we will go to the court when it's bone marrow transplantation or organ donation, and no one can support the person, and no person lacking capacity, and no advanced directive or donor card. For withdrawal treatment for vegetative state, these are some cases of termination of pregnancy. These are capacity cases which should still go to court. I know that there is still some coffee inside the tea, and maybe you have headache, and you feel confused about all of this information that we discussed today. And I can say it is one of the difficult issues to understand in communication, to know what is the role of the patient, and what is the role of doctor, and what is the role of next of kin or last bar attorney. But I can say at the end of this lecture, it's so simple, and I said at the start of the lecture, communication is very easy if you know your role and you know the duties of others. I will go summary now for Mental Health Act. First, we have to decide the patient has capacity or not. Number 1, in the exam, if you are sitting in front of the patient, that is means this patient has capacity. Don't bother yourself, he has capacity or not. Once the patient in front of you, he has capacity until proved otherwise. This is the first rule. Second rule, if the patient has capacity, the patient has capacity and he refuses treatment, he has the right to refuse any medical treatment, even if we feel his decision is unwise decision. Number 3, if he doesn't have capacity, we have to follow the pathway. First, we'll ask advanced directive reading well. If no, we'll ask about any last bar attorney. If no, we'll check the patient wishes or patient best interest. And we explained what we mean by patient best interest, and here we can use this patient best interest. Patient best interest only if the patient doesn't have capacity. We can do the best interest for the patient. Maybe if no last bar attorney, no advanced directive, we will follow to the best interest for the patient. And we explained in details what is meant by independent mental capacity advocate and what is the role of IMCA, and one of the role of IMCA, he can request second opinion. We have to consult in IMCA. If there is no IMCA, we can go to the court of protection. They will appoint one to take a decision on behalf of patient to accept life-sustained treatment. This is the mental capacity decision-making pathway. If you have any inquiries or any questions about this pathway, you can contact me at any time. Feel free to contact me. It is the same, we have to tell the patient at the end of communication. We have to give him a help and support him. Please, in the exam, this mental capacity decision, it comes usually by different ways. Maybe we'll explain to the patient a procedure and the patient is now he is conscious and alert. He has the right to accept or refuse it. Maybe you want to explain to the son or daughter of patient about procedure. One patient come for you with sudden loss of conscious and you did for him CT and you find that through the CT is subdural hematoma and need an urgent surgery to evacuate this hematoma. When you communicate with his son, you ask him and his son deny any advanced directive reading well and also deny last bar attorney, so that we'll ask him what is the wishes of the patient. Does your father express, or did your father express about his wishes when he become in this situation? And also we have to explain to him the benefit and the risk of the procedure. We will come later in the coming lecture to explain what is the best way of explanation of disease and explanation of procedure. It could become again this best way you explain to the patient or explain to a relative or explain to caregiver. And feel free please during exam to become during preparation to contact me, and I am saying and always says that please don't go in confrontation with the patient and the family. You have to become like a political persons. They speak a lot but they will not do anything. We have the same here in communication. You can speak well, you can convince the patient or family, but please don't go in confrontation. Like if the one of member of family insists to refuse a procedure, please don't tell him during the exam it is not your right to refuse this procedure, as your father lack capacity and no advanced directive and no last bar attorney. The decision for the patient, for the team looking after your father, didn't say that to the surrogate or say that to the relative of patient, because you will go in confrontation and you will affect your marks, especially in the welfare. So if you face such situation in the exam and he insists to refuse, tell him the benefit and the current again the benefit of procedure and what is the good things will come to your father or your mother, and if you insist, tell him you can think in this issue for couple if not urgent case for couples of days, and you can come back again and you will do another meeting with consultant. But in cases with urgent like subdural hematuria, we have to convince in polite manner and in professional manner, like political persons. Again, be political person, not in your life, please, in the communication skill exam only. When you're discussing the condition with patient, become like political person. As I said, it says a lot of good things, but they will not do anything. We have to follow this rule, and but in communication only, not in our daily activity. Again, this is the third lecture, and inshallah in coming days we'll arrange the next lecture, maybe about confidentiality or about the explanation of disease. I will decide later. And thanks again for your patient to be with me here for more than 1 hour and 20 minutes, and I hope that it's successful presentation and you will get a lot of information from this presentation. And again, thanks for my dear friend Dr. Khatib for his effort, as he will, after I finish this lecture, I will submit for him the lecture, and he will do some steps to become available for all in social media. I thank him again for his effort. Last, you have to be like this person during preparation and during exam. You have to be confident and thinking. As I said at the start of this lecture, each words have to go through gates before coming off your mouth. Communication is an easy station if you follow instruction. Thank you. Good luck. Assalamu alaikum. For continuity of our course, we are going to discuss today confidentiality. Confidentiality is an essential part in the exam, and a lot of cases we usually face it during our exam or our daily activity. So we will go through this meeting to discuss the confidentiality. Confidentiality if the patient has capacity, confidentiality if the patient lacks capacity, confidentiality that required by law, or confidentiality after death of patient. All these circumstances could face us during the exam, and I will go in details to speak about each situation that we can face it. Confidentiality. Let's start by speaking about introduction. Confidentiality is a center to trust between doctors and patient. Without assurance about confidentiality, patients may be reluctant to seek medical attention or to give doctors the information they need in order to provide good care. But appropriate information sharing is essential to the efficient provision of safe, effective care, both for the individual patient and for wider community of patients. so that confidentiality is the trust between doctor and the patient, and you have to convey this message to the patient. You are keeping his medical information in a secret manner. The assumption that confidentiality is always paramount is as inappropriate as the assumption that disclosure is always permissible, and the decision will need to be tailored to the individual circumstances of the case. Seeking a patient to consent to disclosure of information shows respect and is a part of good communication between doctors and patient. So, in this slide we are speaking about the patient consent before disclose of medical information. Health professional or health care provider is involved in such cases may feel a three-way tension between first part respecting an individual confidence, communicate potentially beneficial information to other family member, and the third part respecting the possibility that those family members may not want to receive such information. This is about the patient confidentiality. We are facing three problems: respecting patient wishes, and respecting the possibility that this family member may or may want to receive such information, and communicate beneficial information to other family member. 2. Where treatment will be instituted or altered. Genetic test of children is likely to be appropriate. Again, genetic test of children is likely to be appropriate. However, where the test will not be a medical benefit for the child or to the child, for sometimes the recommendation suggested a presumption of delay until a child is old enough to choose for him or herself, unless there are compelling reasons to test earlier. So for genetic test for children, we have to outweigh the benefit of the doing the test early, and if this test will lead to a change in the medical condition of patient or will prevent the complication could be happen to the patient, so that we will put the genetic test is if it is benefit to do for a child or not. The benefit is if we did it early, we can treat the condition early or prevent the complications from this problem. I will give an example for this, like patient with cystic fibrosis. If we diagnosed early the patient, we will go through medical management to delay and prevent some complications. So that it is one of the most ethical dilemma. Are we going to do for this patient genetic test or for this child the genetic test or not? So that we are going to do, or if there is any medical benefit for the child to do the test early. If a patient refuses consent to disclosure of his information, you will need to balance your duty to make the care of your patient your first concern against your duty to help protect the other persons from serious harm. Also, this problem we have to gain it and put it in our mind. If the patient refuses to disclose his information, we have conveyed message for the patient that we are concerned about his medical management more than to protect other person from serious harm. Here I will give an example. One of this example is if you have patient has HIV and according to the laws and the regulations you have to inform him that he has to inform his partner. But if the patient insists to refuse to inform his partner, so that you have to explain to him what is the benefit to inform his partner and what is the sequences could be happened if he didn't inform his partner. So you have to reach to a compromise solution with the patient. Don't tell him I am going to inform my partner, your partner about your medical problem. Let the patient to share in the decision so that you tell the patient if you don't like to tell your partner, please you have to use some protection during intimate relationship and think in this issue, and after some times we can discuss this again, but let us now to concern about your medical treatment so that you convey the message well to the patient that first concern is the patient, to manage the patient, and second concern to protect others. So don't waste your time to try to convince the patient to disclose his information other than his medical treatment is our first concern. Now, when do you have to disclose confidentiality? When we are going to disclose confidentiality, confidentiality is an important duty, but it is not absolute. You can disclose the personal information so that it is our duty to keep everything confidential, but not everything is absolute. In communication, there is a message you have to put in your mind. Nothing is right all time. No thing is right all time. Every case is a different than our case. So it is not absolutely contraindication to disclose on confidentiality. So when do you have to disclose confidentiality? First, if it is required by law. Second, the patient consent. Either this consent, implied consent, or express consent. Or number three, it is justified in public interest. We have now three reasons to breach the confidentiality. If it is required by law, if it is justified in public interest, or patient consent. This consent could be implied consent or expressed consent. We have to go through steps for disclose the confidentiality. When disclosing the information about the patient, you as a healthcare provider must use coded information if practical and if it will serve the purpose. So that first we have to use coded information so that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that we can use coded information. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what is the information we are discussing. So that during our discussion with the patient, we have to use coded information so that he will understand what discussion with the patient about confidentiality, and this patient will say it in research. You have to be sure to inform the patient your personal information will be coded and will use the code number for your case. Number one, use code information. Be satisfied that we have to be satisfied that the patient has ready access to information that explains that their personal information might be disclosed for the sake of their own care or for local clinical audit, and that they can object. Other step is hasn't objected. The patient didn't refuse to disclose this information. If we are going to disclose information like medical research, we have to use code. We have to take a consent from the patient, as the patient didn't object to disclose information. We have to give the patient express consent. Express consent, it is written consent. If identifiable information is to be disclosed for the purposes other than their care or local clinical audit, unless the disclosure is required by law or can be justified in public interest. For clinical information to share with other persons, other medical team members, to be specified as a medical team member, we can use implied consent. But if we are going to use this information away from the medical team or local clinical audit, we have to take express consent from the patient unless it's required by law or justified in public interest. We have to keep the disclosure to be minimum necessary. We have to keep up to date with and observe all relevant legal requirements, including the common law and the data protection legalization. Data protection legislation. Disclosure required by law. You must disclose information to satisfy a specific constitutional or statutory requirement, such as notification of known case suspected of certain infectious disease. If your patient has tuberculosis, it is required by law to inform the MHS about that. We have to disclose the information if it is required by court. If there is law or required by court, we have to disclose information without consent from the patient. Very important thing, you mustn't disclose personal information to third party, such as solicitor, police officer, or officer of a court without the patient express consent, unless it is required by law or can be justified in public interest. Sometimes in the exam you will face that the patient will inform you, "Doctor, please didn't inform the company about my medical problem." Yes, he has the rights for that. We will not disclose confidentiality unless it is required by law. If the patient has tuberculosis, we have to inform his company to inform MHS and make tracing for the contact. But at the same time, if the patient has hypertension, we didn't have the right to disclose the information to his company as if it is not required by law or not justified in public interest. Confidential medical care is recognized in law as being in the public interest. However, there can also be public interest in disclosing information to protect individuals or society from risk of serious harm, such as serious communicable disease or serious crime. Before disclosure of information, there is important issue. We have to inform the patient we are going to disclose his information. Actually, if you examine and you face a case of epilepsy and you try to convince the patient to stop driving, we have a lot of steps in this issue. First, you have to express for your patient, what do you think if you lose your consciousness during the activity? Do you think it is a harm for you? It's really important to start with the patient for that. And tell the patient this attack could be happened at any time without any previous complaint, so that if it's happened to you during the driving, you will be danger for yourself. Please see this issue. Please listen for this issue. First, confirm with your patient. Try to convey the message for that. Don't tell the patient if you make an accident you will be harmful for public. Now, start by the patient. If this attack happened to you during the driving, you will be harmful for yourself and you may be lost your life. So that we are going to make you live in a safe environment. This is a very, very important issue we have to discuss with the patient. After that, tell the patient this may be harmful also to other persons. If the patient is married to him, suppose that this attack happened to you during drive and your kids with you in the car, so that it could be a problem for your kids. If the patient till now is still not convincing, tell him if you continue drive after now, your license will be invalid. It is not a drive license, it's not a vehicle license, but also insurance license. So that you have to pilot and go step by step. If the patient refuses after that, tell the patient, please can you stop driving for a couple of weeks and think this issue and try to, and we will discuss this issue in the next meeting. This is the way during discussion with the patient. But if the examiner going to discuss with you, tell him if the patient is still first to refuse driving, to refuse stop driving, we have to inform the DVLA. I am the one who have to inform the DVLA, and before inform the DVLA, who will document that in his file and inform the patient to stop driving, and at the same time I have to inform the patient that I am going to disclose his information, so that you should inform the patient you are going to disclose his information. That is the right of the patient. Again, this is one of the wisdom in communication regarding the confidentiality. You must weigh the harms that are likely to be arise from non-disclosure of information against the possible harm, both to patient and to overall trust between doctors and patients arising from the release of that information. Please don't lose the trust with your patient. Try to reach to a compromise solution for the problem. If the patient doesn't like to stop driving now, give him 2 weeks and discuss that in the next meeting. If the patient doesn't want to inform his partner about HIV, give him a couple of weeks, use protected intimate relationship, and after 2 weeks you can discuss and raise the issue again with him. So you have to outweigh the benefit and risk of disclosure of information. Next, if the patient lack capacity. If the patient doesn't have capacity, when making a decision about whether to disclose information about patient who lack capacity, you must make the care of patient your first concern. Again, our first concern is the patient, not other public, not other people, not person, not relative. This message we have to convey when to the patient, make the care of patient your first concern. We have to respect the patient dignity and privacy. We can involve the patient later before disclose of information if the patient capacity is temporarily lost. We have to define if the patient lacking capacity is a permanent or a temporary. If temporary or permanent, and if it is permanent lacking capacity, we have to outweigh the benefit of disclosure of information. But if the temporary losing capacity, whether the decision to disclose information would be reasonably wait until they regain capacity. I mean here if the patient lacking capacity for temporary cause, we have to make a plan. If disclose information will give a benefit or not. If we give a benefit, we have to disclose it. If not, we have to wait until the patient regain his conscious or his capacity. We have to respect the patient's previous expressed wishes. If the patient has an advanced directive of leaving the will, we have to respect it. Also to check the view of the other close to the patient, like last bar attorney, that maybe it is appointed by the patient to take the decision on behalf of him. As we know that consent could be implied consent or express consent. Implied consent, maybe the patient can give us implied consent to disclose his information, especially during sharing information with the health care team or with other providing the care. If you are taking the care of patient, we can take a verbal consent from the patient before sharing the information with other health care provider. Like patient has tuberculosis and you inform him you have tuberculosis. When you finish the discussion with the patient, tell him I will inform the TB nurse, I will inform the tuberculosis nurse and GP. If the patient doesn't object, that means he gives implied consent. So that most of patient understand and accept that information must be shared with the health care team in order to provide a good or a comprehensive plan of care. You should make sure information is readily available to patient, explaining that unless they object. If the patient refuses, that is right for the patient to refuse, but we have to try to convince this patient to take a consent. we must respect the patient wishes, and if the patient objects to personal information to be shared with healthcare team or other providing care, unless again, every now and then you will listen to this issue, unless disclosure would be justified in public interest. If a patient objected to a disclose that you consider essential to the provision of safe care, you should explain to your patient you can't refer them or otherwise arrange for their treatment without disclosing information. If you are going to inform the patient that I will refer you to the surgeon and I will tell you about his condition, and this surgeon will share in information and share in medical treatment, and if the patient refuses to share his information, you have to inform him your care will not be comprehensive and it will affect your care. For implied consent, circumstances may arise in which a patient can be informed about the disclosure of information. For example, in a medical emergency, in such a case, you should pass relative information clearly to those providing the patient care. If and when the patient is capable of understanding, you should inform him that how their personal information was disclosed, and if it was in a way they wouldn't expressed or reasonably expected. In this paragraph, we will not face an exam. Actually, the patient will do the best interest for the patient if the patient lack capacity. Number one, as we said about the breach confidentiality after implied consent. Number one, it was for sharing his information with the medical team. Number two, for local clinical audit. Maybe we will disclose identifiable information, provided you are satisfied that the patient doesn't have any object to share his information, and we explain to the patient about the local clinical audit and what they have to be the right to object, like in research. If the patient does object to disclose his information, you should explain why this information is needed and how this may benefit for his own and other care. If it is not possible to provide safe care without disclosing the information for audit, you should explain this to the patient and the option open to him. Disclose information. You have to taking the patient consent. You have to take the patient consent, either verbal or implied consent, before disclose his information, unless it is required by law or public interest. Disclosure for which express consent should be sought. Express consent. You should seek a potential express consent before disclosing identifiable information for purposes other than provision of care or local clinical audit. So, in summary, for local clinical audit and for care of the patient with other medical staff, no need to take express consent. Implied consent is enough. if the patient refuses consent or if it is not practical to give their consent, information can still be disclosed if it is required by law or can be justified in public interest. If the patient refuses to give a consent to disclose his information, we can disclose this information if it is required by law or in public interest. Again, we will go back to genetic information. Most patients will really, all patients usually in the life or during the daily activity will share information about their own health with their children or relatives, particularly if they are advised that it might help this relative. If we are going to inform the patient about genetic illness, we have to tell him, please inform your relative. If we found the genetic illness could be autosomal dominant condition, you have to tell her, you have to inform your brothers and sisters, because one of them could have the disease and he didn't know he has this disease, so that we can get a prophylaxis for him or try to know if he has a problem or not. So that the benefit to inform the relative, we have to inform the patient to inform the relative why. To get a prophylaxis or other preventive treatment or intervention for those relatives could be affected by the disease, make use of increased surveillance or other investigations, prepare for potential health problem. So that we have to share information with the patient and inform him, he has to inform the relative, he should inform the relative why to get a prophylaxis or to avoid serious complications. Maybe we will give a preventive treatment for him. However, some patient might refuse to consent to disclose of his information that would benefit to other relatives. In these circumstances, we have two options. Disclosure could be justified in public interest, it is one option, or we have to outweigh the benefit and risk and reach for a compromise solution. I mean, if the patient refuses consent to disclose, you will need to balance your duty to make care of your patient your first concern against your duty to help protect the other person from serious harm. Again, I will tell the patient, I am going to tell you this medical problem could be serious problem, and we have to concentrate to prevent the progression of this disease and to treat some any symptoms could be arise. But also we have to put in our mind this disease could be affecting your brother or sister, and we have to inform him to make a test to check if they have a disease or not, because we can prevent this disease from progression, or we can give him a treatment to settle this disease before it be manifest by serious complications. This is only an example I discussed. Sometimes there is no any prevention of progression of the disease that transmitted through genes. So we have to convey a message for the patient. The patient, you are the first concern of us. Now we already mentioned about the patient has capacity, the patient lack capacity, or the patient, when the patient we can take from him verbal consent or implied consent, and when we have to take written consent. So also we shared genetic information, and we told it could be justified in the public interest, or we can outweigh the benefit and risk of information and tell the patient you are the first concern for us, and try to reach to a compromise solution with the patient. For the patient has been died, the patient has been died, we can breach his confidentiality? Could be. For example, if this information will help the crawler so that we can breach the confidentiality to the crawler. When disclosure is required by law or justified in public interest. Number one, if it will help the crawler or justified by law or public interest. Maybe for this certificate, yes, should be completed honestly and fully. For local clinical audit, how many cases this by heart attack, we can breach the confidentiality. So that for this, we can breach the confidentiality to the crawler if it is justified in public interest or by law, or if it is used for clinical audit by National Health Service, or this certificate should be or must be complete honestly and fully. When a partner or close relative or friend asks for information about circumstances of an adult death, and you have no reason to believe that the patient would have object to such a closure. For the public health surveillance, in which the case information should be coded unless that would be defeat the purpose. When a parent asks for any information about the circumstances related to death of a child. So that for a child, if the parent asks what is the cause of this, we can disclose his information. Or for local clinical audit, or if we need to feel there is no objection from the patient to breach the confidentiality of his illness to his relative, or it is justified by law, or it is justified by public interest. This is items we can breach the confidentiality of the patient after he passed away. Now, in summary, confidentiality is a trust between a physician and the doctor. If you lost your trust between you and the patient, you will lose a lot of information that is in practical life. You have to keep all information confidential unless it is required by law or it is justified in public interest. This is a message for all information should be kept confidential unless it is required by law or public interest to disclose it. You have to take a consent from the patient before disclose his information. This consent could be implied consent or express consent. Implied consent in the medical health during discussion with the other clinical care provider or health care provider, and also for local clinical audit. Because there is two items we can disclose information with implied consent: for discussion of the case with the other clinical team member or for clinical audit. Express consent usually will take it if this patient will participate in the research. Before disclosing information, you have to inform the patient you are going to disclose his information. Try to reach for a compromise solution with the patient and didn't go with confrontation with the patient. Don't tell him in the exam you have the right as a doctor to disclose his information if he insists to refuse that. This is not a practical. This is not a practical way in communications. We have to give the patient opportunity to think and give him a chance to think, and we can arrange meeting after couple of days or week and discuss this issue again. And we have to inform the patient that you can avoid driving for 2 weeks until we discuss this issue again, or you have to use you have to use a barrier in your intimate relationship to avoid transmission of the disease like HIV or HPV to your partner. Disclosure for information for other third party like companies, solicitors or relative. It is not right to disclose the information to other third party without consent from the patient. So that usually when we are going to discuss a case of the communication and his relative is discussing the case with us, we have two options. If the patient has capacity or not have capacity. If the patient has capacity, we have to inform the relative if you have a consent to discuss the condition with us or not. And we have to tell him in a polite way, as I said before, I believe that you have a consent from your father to discuss the condition with you if the patient is conscious. But if the patient is unconscious, just only are you next of kin of Mr. Ali? Yes. And if the examiner told us but the patient doesn't have any, the patient doesn't give consent to his son to discuss the condition with you, how come you discuss and breach some confidential information to his relative without consent of the patient? At this time, we can reply for the examiner, I discuss the case of the patient with him because for this patient lacking capacity, and we are doing the best interest for the patient. And one of this best interest of the patient to know the patient wishes from his relative. We can also breach the confidentiality after this, like it is required by law or public interest for clinical audit, or if we need to see the patient doesn't object to disclose information to his relative, if the child this and the parent want to know some circumstances about their child illness. This is a confidentiality. And also we spoke about the genetic information, and we have to try to convince the patient to inform his relative about his genetic illness, because this genetic illness could be prevented if we found it early, or could be avoid the complication of some treatment started early, or delay the prevention of the disease. So that we have to convince the patient to inform his relative about genetic illness or his partner. And if the patient refuses to disclose information, again, don't go in confrontation and let the patient to think this issue for a couple of weeks, and we can discuss the issue later. This is confidentiality. I hope that it help this confidentiality lecture will help others to understand the confidentiality statement, and when we have and to breach the confidentiality, and when we have to take a consent, and how can we reach for a compromise solution with the patient if the patient insists to refuse the confidentiality, and continuous meeting with the patient until we reach for obstacle. This patient will not inform his partner about his problem like HIV, so that this is the way we'll discuss with the examiner. He will tell you if the patient insists to refuse to breach the confidentiality, what are you going to do? You will tell him, I will try to convince, I will make another meeting, and I will try to explain more and more. But the examiner will tell you if he insists to refuse to breach the confidentiality, here you are going to inform the examiner, I am the one who breached the confidentiality, and before breach the confidentiality, I have to inform the patient I am going to breach his confidentiality. This is confidentiality statement, and keep everything secret between us. Confidentiality is one of the major ethical dilemma in exam. Please don't inform anyone about this statement. Confidentiality is one of the ethical dilemma in the exam. keep this confidential between us, and see you later in the next lecture. I hope this lecture is helpful for other, and thanks again for Dr. Khatib for the effort that he are going to do after I submit for him this lecture. And at the same time, I am going to be prepared for next lecture. It will be breaking the bad news busway. Thank you. See you. Bye bye. Bismillahirrahmanirrahim. As we are going together to start, once we started our lecture about communication and our story when we started first lecture, how to prepare yourself. Then we started we gave a lecture about introduction of communication. Then we explained Mental Capacity Act, then confidentiality. Now we are going to start today a breaking bad news. Breaking bad news, one of the famous situation you could face in exam, more than 60% of the case in the exam is breaking bad news. Breaking bad news, a lot of candidates consider it is a difficult case, and a lot of candidates consider it is a difficult to pass in station with breaking bad news. They consider breaking bad news case like a sea that facing the people they can't swim. So today I will do my best to simplify it, breaking bad news, and make it easy. Now we will go through this sea, and we will use this boat to go together inside the sea slowly until we cross it to the other side. Breaking bad news, let you first to enjoy by this lecture, and give me your attention for the next few minutes that we will discuss the pathway of breaking bad news. If you are going through the sea with your colleague in a cruise, you have to rule. This rule that put it by the captain of the cruise. First rule, the boat captain is always right. Again, the first rule, the boat captain is always right. The second rule, if the boat captain is wrong, refer to rule 1. If you feel the captain of the boat is wrong, please again refer to rule 1 that said the boat captain is always right. So this diagram that we will see, or this pathway that we will discuss, that is right. No need to add more, or no need to remove any information of this pathway. Everything you need is present in these lectures, and the only difference between case and the case is the title of the diagnosis or the cause of the breaking bad news. Let us to agree, breaking bad news. An expert in breaking bad news is not someone who gets it right every time. An expert in breaking bad news, he or she is merely someone who gets it wrong less often. This is the wisdom. is bad news? Bad news is information which adversely and seriously affects an individual's view of his or her future. This is breaking bad news. Any bad news, it is that affected seriously or adversely the future of patient. So that breaking bad news could be terminal cancer, palliative cancer, or treated cancer, or chronic progressive illness. This is the bad news, the definition of bad news. Please focus with me. Why is it important? It is important because it's frequent that we faced it usually in our life and during the exam also. It is stressful when doctor is inexperienced, the patient is young, or there is limited perspective for successful treatment. Also, we can say, in the breaking bad news, what remains unspoken is unspeakable. Leave this in your mind, or put it in your mind. This is the message. What remains unspoken is unspeakable. What is the objective? Objectives of breaking bad news. When a bad news needs to be conveyed to a patient, there are 4 objectives that needs to be achieved during this discussion. We have 4 objectives. Number 1, number 2, number 3, and number 4. For number 1, please keep your attention with me. Assess patient and the relative perception of their illness. What does that mean? It's not difficult. We explained it before. We explained before in the introduction how to prepare the patient for breaking the bad news. By asking the patient or relative how you feel now, or how do you feel now, how much you know about your illness, did anyone inform you why we requested this investigation for you, and lastly, what is your expectation about your illness. That is mean assessing patient relative perception of their illness. This is the first objective. Second one is giving the diagnosis and information. Explain what is the breaking bad news and what is the criteria and the management plan of this bad news. Number 3, support. We have to support the patient socially, or support him physically, or support for his relative according to the situation. We have to share and involving the patient in decision making and further management. So we have 4 objectives. Number 1, assess the patient relative perception of their illness. Number 2, giving the diagnosis and information. Number 3 is support. Number 4, involving the patient in decision making and further management. Till now, we are still going slowly through the sea. We didn't go deep and deep. We're still in the beach. We can return back. If you don't mind, we can return back again. But if you want to go deep and deep, please come with me. Now, we have steps for breaking bad news. Breaking the bad news is not a subject everyone has to speak in it. You have to be confident during the speaking. You have to know what is the best way of breaking the bad news. If you enter your exam without arrangement previous best way in your mind how to break bad news, definitely you will not pass. So come to first thing in the steps for breaking bad news. If you would like to take coffee, please take it. No problem. Before you drink your coffee, you have to touch the cup. If this cup is hot or not, so that you have to prepare yourself first. You have to prepare the meeting with the patient. So, if you have a cup of coffee now, touch it before you drink. It may be still hot and you may get burn in your mouth. I know that it is very painful. So, now we go deep and deep in the sea to know what are steps in breaking bad news. Number one, preparation. Before you drink, you have to feel the cup, if it is hot or not, if you will break bad news now or not. So, preparation, as we said before, introduce yourself and identify the patient. Know all the facts and confirm agenda of meeting. Ensure privacy. Find out what the patient relative wants present. So that I will give an example again. So I will tell the captain to stop. We will not go deep now to the sea. Good morning, Mr. Ali. I am Dr. Ahmed, Senior House Officer in the Gastroenterology Department. Nice to meet you. Nice to meet you, Doctor. Mr. Ali, I confirm that we are here today to discuss the result of the camera test that done for you last week. Is that alright for you? Yes, Doctor, that's right. Out of respect for you, Mr. Ali, do you want any member of the family to attend this meeting with you? No, Doctor, no. I would like to know what's about my diagnosis. Yes, I feel that I can go to Hollywood after this introduction. So, after you prepare yourself and prepare the patient in the introduction that we explained before in the introduction of communication that contains 4 or 5 steps according to for whom we discussed, the patient or relative. So, first, preparation. You have to prepare yourself. Second step, what does the patient know? You have to check the mind of the patient, how this patient is thinking. How the patient is thinking in his illness. If the patient suspected he has a terminal disease or not, or if the patient suspected he doesn't have any serious illness, it's different from one patient to another. So that the first patient he has suspected that he has cancer, his response will be friendly with you. But the patient who doesn't suspect cancer, the patient will feel frustrated and his response may be very angry about that and about the diagnosis of chronic illness. What does the patient know? We have to start by open questions. As we learned a lot, you have to open the view for you. So that, as I told you, when you catch your cup, when you drink the first one, you drink small amount. You have to taste it. You have to check. Even you hold it and it's not hot, the first you have to feel it. It is still hot or not. You are afraid from the ulcer. So that we are afraid to break bad news directly. So that we have to start by open-ended questions. The start, as I said before, we have to tell the patient how you feel now. That's actually in our daily activity. Mr. Ali, how do you feel now? the first question. Please don't start any communication station without this question. How do you feel now? If you are speaking into the patient, or if you are speaking also to a relative, how do you feel now, or how your father feeling now? So it is a vital question. It is the first question to prepare the rapport between you and the patient. The next one, how much you know about your illness, and we said that before. The third one, do you know why we did the investigation and what we were looking for? The third question. By the other way, we can say also what have you already been told about this illness? Number 5, what is your expectation about the result of investigations? So it is a comprehensive questions. We will start by open one and tailored it to closed questions. So first one, how did it all started? As I told you, when you catch the cup of tea or coffee, first you will feel it, is it still hot or not? Then how much you know about your illness? Do you know why we did the investigation and why we were looking for? Number 4, what have you already been told about your illness? Number 5, what is your expectation about the result of investigations? These are 5 questions we have to build the rapport to the patient or relative. For the step number 3, is more information wanted? The patient brain is open and closed. He wants to know everything. Please don't force to give the patient information, and you have to tell him, would you like me to explain the problem as we understand it so far? Do you want to know everything about your illness? Are you the sort of person who likes to know everything about his condition? All the same meaning. You don't tell all this step, you have only to mention for him one. This need more information, you have to tell the patient about that after you giving him the diagnosis. After these 4 or 5 questions, then you will breaking bad news. After that, you will tell the patient, is more information wanted? Would you like to know everything about your condition? Do you want to know everything about your illness? Any one of these 3 questions, you can use it. Now, giving a warning shot. You have to tell the patient or relative, I'm afraid it looks rather serious. Then inform him about the diagnosis. Or you can say, the result of investigation has been released today. Then silent please for 2 or 3 seconds. It is not that as we hoped. Then silent. Then inform him about the diagnosis. Or you can say, I'm afraid it doesn't look like a straightforward condition. Then both will explain the diagnosis. Or you can say, I'm afraid that things looks more complicated than we had hoped. Then explain to the patient. In one of 4 paragraphs, you can use it. So it is give a warning shot by speaking clearly and shortly, and start by always, I am afraid, I am sorry, this information is not straightforward, your diagnosis. This is a warning shot. Give time to the patient to allow denial. This is the wrong way. If you entered directly after you give the warning shot, it is wrong. So that you have to allow your patient to feel denial. This is the communication. Allow the patient to control the amount of information they receive by keep silent for second. You have to keep silent only second, not keep silent for 1 or 2 minutes. Ask the patient if he wants from you to continue the discussion or not. Then ask one of the following questions. How do you feel now? How does this new make you feel? I can see that was a shock for you. What is going in your mind? You have to respond to the patient emotionally through sympathy and empathy. This is allow denial. We can go back again to summarize until this step. Deep breathe, take deep breath. You will tell the patient, how do you feel now? Yes, doctor, I still have shorts of breath. I still feel tiredness and easy fatigue. I can't sleep well at the night. I am sorry for that. Could you tell me how much you know about your illness? Yes, doctor. I had this shorts of breath long time. Now for 6 months. I was thinking this problem related to my smoking. And I was told by my friend it is one of obstructive lung disease due to smoking. But it is bothering me a lot. I start to lose weight. Then I sought medical advice and I went for GP. He requested for me imaging on the chest. Then he referred me for your consultant. Could you tell me also, Mr. Ali, do you know why we requested this investigation for you, or my consultant informed you why he is running this investigation for you? Yes, doctor. Your consultant informed me that he is looking for the cause of shortness of breath because this imaging of the chest that done is not conclusive for him. Mr. Ali, what are your expectations about the result of investigation? Doctor, I am smoking for a long time, and this shortness of breath usually come for the person who usually smoke for a long time. And I have a lot of colleagues that are smoker, and they complaining from shortness of breath. Maybe this leads to smoking, and it could be simple thing. Yes, Mr. Ali. The result of the imaging of the chest has been released today. I am sorry to inform you that the result is not straightforward. Mr. Ali, the result shows that you have an osteoporosis. I am sorry to say that. This osteoporosis is cancer. I am sorry, Mr. Ali, to inform this bad news for you, but this is all the result that come for us. So that you did breaking, you giving warning shot. You have to keep silent for a moment. You have to allow the patient to control the amount of information that given to him. So that keep silent. This silent, the patient will not speak. You have to end this silent by saying one of the questions. I see that is a shock for you. Could you tell me what going on inside your mind? Mr. Ali, if you want to end this discussion now and then come back again to discuss your illness, we can do that. No, doctor, no. It's a shock, really a shock for me. Then tell him, Mr. Ali, do you want to know everything about your illness? Yes, doctor, actually, I want to know everything about my illness. This is the first 5 steps in breaking bad news. Then you have to allow denial. Don't go deep without cut the denial of the patient. If you go deep early, you will go through wrong way. So the first rule that we told and we speak about it from the start, the captain is right always. During the cruise, follow up the instruction of the captain. Second rule, as I said, if the captain is wrong, please return back to the first rule. He is right. After you allow the patient to deny, I think now the cup of coffee is not too hot, so drink, don't be afraid. After you allow denial, so that the patient will be not hot, I'll give an example for the hot coffee. So you can drink now your coffee and you will explain details. You have to explain the details of the illness step by step. In short sentence, clearly, avoid any jargon. State the information simply, clearly, and sensitively. Provide information in small chunks. Avoid false reassurance. Don't be discouraging. Be honest in your statement. Remember, multidisciplinary team and multidisciplinary professional support put in your mind. Don't start the treatment, please, again and again and again. Put this sentence in a circle. Don't start the treatment for the patient without saying for him, we are going to do for you multidisciplinary team. This team will include 1, 2, 3, 4. Please, again, don't start the treatment without telling the patient we are going through multidisciplinary team. Some candid explain to the patient the treatment, and after he explained, he will tell the patient will go through multidisciplinary team. That's not right at all. You have to be organized. You are working together now to put you in the right way. So that you have to be organized from now. You have to tell the patient from the start there is multidisciplinary team looking after you. The content of this team may be cancer doctor, maybe safety doctor, maybe nurse, maybe palliative care team, your GB. So you have to mention it, please. You are not one-man show. You are not the doctor. Only one doctor cannot treat the patient. Put multidisciplinary team in your mind. Again, put in your multidisciplinary team in your mind. Now we reach the half of the sea. It is simple. See, we still have another half. We can cross it to another beach. After we explain the disease and what is the information and the management plan, including the multidisciplinary team, you have to ask the patient. And very, very important, please. Sometimes, as I said in the introduction, something not spoken, but it is running in the scenario. You first all explain the illness. You have to ask some questions related to job of the patient. It could be the cause, and if you forget it, you will lose the compensation. Is the patient working in mesothelioma, working in asbestos, and he developed mesothelioma? If you forget to ask him about his job, then you lost one of the ethical issue in this scenario. Is the compensation. Job is very important for each case. Smoking is important. Any medical problem in the past may be related to the new diagnosis. Who who is taking care of the patient or with whom the patient live? Any financial problem, so that it is a vital conscious. Something are hidden inside the scenarios. Sometimes, as I mentioned before, you are speaking about the patient has Parkinson's disease. And one of complication of this Parkinson is dementia. If you don't ask the patient who is taking care of him for whom, or who is looking after him in the home, you lost a lot of marks because you didn't treat the patient totally. So that you have to focus in your patient. You haven't to focus only on the disease. This is one of the important rules in medicine, not in communication or history or clinical. Please focus in your patient. Don't focus the disease only. So then don't explain Parkinson's disease and forget to tell the patient about who is taking care of him from the house, because this patient has risk of fall. The patient has dementia. Now we'll go to listen to concern of the patient. After you finish your task and remark the state, ask the patient, what are your concern? Or could you tell me what's your concern now? Please, this is very important. You have to answer the concern once you asked it. One of the mistakes that the candidate do it, he asked the concern, then the patient informed him about his concern, and we go back again to explain something. No, not allowed, please. Once you ask the concern, answer this concern. You have always show the sympathy and empathy for patient by saying it must be very hard for you. I can't understand, this is very upsetting for you. Or by another word, you can say every now and then, I am sorry for that. Don't depend on you informed at the introduction or in the breaking bad news, in the warning shot you informed him about the sympathy. No, sympathy and empathy is a continuous process during all time of breaking bad news. So encourage ventilation of feeling. You have to allow the patient to speak and the vital step to take patient satisfaction. Now we are going now inside the sea, and the cruise it goes smoothly without any problem. After concern and plan of treatment and information to the patient, you have to make summary. You have to check understanding and giving help to the patient. Last step, or further. If any change in the future, you have to tell the patient. Any information or any other concern, you have to answer it. Ensure that patient is not left alone at the end of consultation, and think about whom they have at home with them for further support. So that, as I told you, breaking bad news, sympathy and empathy is a continuous process. Even after you breaking bad news and summarize and end of discussion and giving help to the patient, you have to ask him, who will drive you to home? If anyone is carrying you in the home, could I arrange anyone to drive you to the home? So you have to order further thing. This is the 2 steps in breaking bad news. Now we reach to the other beach, but we are still inside the boat. The captain always says instruction before we start the cruise and during the end of the cruise. pitfalls in breaking bad news. Pitfalls in breaking bad news. First thing, breaking bad news without exploring the patient willingness to know them. What does that mean? I have to take a consent from the patient at the start. Mr. Ali, are we going to discuss, we are going to discuss your illness. Is that alright for you? This agenda of the meeting. So that you have to take a verbal consent or implied consent from the patient. Next one is not establish background knowledge. What is mean background knowledge? I mean if you didn't ask the patient how do you feel now and how much you know about your illness and what is your expectation. This is a big false in breaking bad news. If you didn't ask it, you will not give mark for it. By other word, I can say what is not documented, that is not done, not marked. If you break bad news early without preparing the patient by a reasonable warning shot, you will tell the patient, you have cancer. Or the result shows that you have cancer without warning shot, so that we are now at the end of the cruise and you have to take it. You have to prepare the patient to this breaking bad news. If you didn't, this is wrong. Don't delay bad news because you are fearing of the patient to action. Sometimes patient treated for chest infection, and one of the common case I will explain it during the scenario, during the interactive session. Patient wrongly treated as gastroenteritis and doesn't respond to medication, and after that colonoscopy done and there is cancer. When you start to tell the patient about or preparing him, the patient was angry. Doctor, I have 6 months diarrhea. I went many times for GB and he told me many times I have irritable bowel syndrome and he prescribed for me medication and this medication doesn't help. I'm sorry doctor, this is bad treatment. If you face one patient like that in exam, you will feel frustrated. You will hide inside the desk. No, we are confident. We are discussed a lot of cases such like this case. You have to sit in your chair and feel confident most of the time. Let the patient to say what you want to say. You have to react only to my sympathy and illness way, but you are the leader, you are the captain. You have to drive in the way that you want, not as the patient want. So don't delay bad news in a fear of the patient reaction. In such cases, tell the patient that I am sorry for what's happening, and I feel that it's a hard time for you, but also at the same time let us to discuss what is going on with you now. You have to give them a cup of tea, not in the exam actually, but by your words. Give him a flower by your words. The tongue also always saying a good words, and we can say sometimes only a bad words. Don't delay the bad news in a fear of the patient reaction. Don't hesitate when you ask direct question by the patient. Is that cancer? If the patient you told the patient, I'm sorry to inform you that the result of investigation released today, and the result not as we hoped. The result showed that there is an growth. The patient may say, is it cancer? You have to be confident and don't hesitate. Don't tell this growth it is a probability of cancer. No, if it is written in the scenario, it is cleared cancer, you have to tell the patient, I am sorry to inform you that is it cancer, it is cancer. The patient maybe will tell you, are you sure, doctor? Yes, I'm sorry to say the result of investigation that released is it cancer, and we are sure about that. Please use the we, not I, because we are a team looking after for the patient. If the patient tell you, I am going to die, doctor, you have to answer this question like political person, and I will say that in the next slides. Remember to break bad news at an appropriate time, to leave adequate amount of time to deal with the patient reaction. Other concern or discussion other relative issue. Maybe there is some hidden issue like post-mortem examination, or don't attend resuscitation, or compensation, or explain a procedure. Sometimes there is breaking bad news in patient. It is a probability of there is a probability of cancer. That's not confirmed yet. You have lung mass and intestinal lymph node, and the radiologist suggested that you have to tissue snip from this mass, so that you have still time to explain the biopsy. Never say to the patient nothing can be done, or the patient will lose or hope. If the patient asks you, is there any treatment for such cases, you have to inform him, I am sorry to inform you that this type of illness is not curable, but we are going to treat any symptoms related to this illness. Be optimistic, don't be dishonest. Optimistic here by don't say and didn't tell the patient about something not there. If the patient asks you, is there any treatment, don't reply for that, maybe there is treatment. No. If the palliative treatment, yes, there is palliative treatment, it is different totally than the curable treatment. One of the pitfalls also, not exploring the patient information need. Not acknowledge the patient's distress. Not exploring the patient concern. It is very common question in exam. What's your concern? Don't forget it at all. So now we finished breaking bad news. Breaking the bad news, as I mentioned, one of the common cases in the exam. Anything that affects the patient future physically or mentally, we can consider it as a breaking the bad news. Breaking the bad news could be cancer, either this cancer is treatable, or probability of treatment for the cancer, like localized cancer without metastasis, or non-curable palliative treatment, or chronic progressive illness. We explained the introduction, and we explained the starting of or preparing the patient to breaking bad news, and we mentioned clearly breaking the bad news multi-19. Again, please, I emphasize about that. Please, I emphasized again about multi-19. In any case, breaking the bad news, and you have the patient is palliative treatment, ask the patient after you end of the demorphine state and the social history, do you have any advanced directive or living well? Maybe the patient needs something and we have to consider it. Then end of discussion. Then ask who will give support to the patient in the home. who will drive him back to the home. We can arrange that. What are common questions in the breaking bad news? First one, the patient will tell you, is it cancer, doctor? If the diagnosis is established, you have to say, I am sorry to say that the diagnosis has been confirmed, you have cancer. And leave time to the patient to feel and give information. If the diagnosis is uncertain, you will tell the patient like that. The investigation has been released, and there is a lot of possibility that might cause your problem, and one of these possibility is cancer. But we are not sure about the final diagnosis, as we want to run some investigation for you to confirm the diagnosis. This is if you confirm it or establish you have cancer, okay. If not established, that's written in the scenario, you will take a biopsy to confirm the diagnosis. This is the answer of the question, is it cancer or not? Next one, I am going to die. How long I have got to live? You have to reply, no one knows what will be happened in the future. So I don't like to give you figure. Everybody is different. It may be months rather than year, but it is unlikely to be few weeks. Let us look forward for control of your symptoms like pain and refer you to the team that will decide the plan of care. I am going to die, or how long I have got to live. Maybe the patient will ask the same question by another way when he tell you that, doctor, the wedding party of my daughter is after 6 months. Is there any possibility to attend this wedding party? The same question, I am going to die, it's the same. If the patient asked you, can it be cured, or can this disease be cured, you have to answer that I don't see the disease will go away completely. However, we can do a lot of things to help you cope with it and make you free of pain and in a good shape. Last one, maybe the relative will tell you, please doctor, don't inform the patient about the diagnosis. One of the common questions also. We can reply, I appreciate that you know your father much better than us. However, having seen this situation many times before telling the patient the truth is usually what he wants and is best in long term. Most people know when there is something serious wrong and find out can be a relief. I would like to know that you doesn't want to know why. I would like to know why you doesn't want to know her diagnosis. I will talk to him or her and give him or her small amount of information. And if he or she doesn't want to know, I will not tell him or her about the diagnosis. Also, I want to emphasize about that your father or mother is competent and he or she can take their own decision. Simply, if the patient is conscious and has capacity, and this patient, one of his relatives speaking with you after consent from the patient, and the relative informed you that please doctor don't inform him about the diagnosis. We can reply by political way, I appreciate that. You know your father much better than us. But in such cases, we faced many patients before, and it is better to inform him the trust from the start. As there is some plan of management, the patient will ask us why you will give me this medication and why you will do for me this investigation. And by the other word, your father is competent and he is the right to know everything about his decision, about his illness, and we can talk on decision. But if I would like to tell you that I will give him small information about his illness, but if you want more and information, I will say for him about his illness if you want more. This is the answer of this question. Now we reach to the other beach, and as I said, breaking the bad news, one of the simple and easy case in the exam. Don't feel frustrated if you faced breaking the bad news. I feel you become more confident now after you listen to this lecture, and now we have a pathway, we have a guide, and we have a boat. We can go inside it alone, inside the sea, without need any instruction from others. Breaking the bad news, as I said, it could be for cancer or chronic progressive illness. I will give some tips and or message to put in your mind before end this lecture. Message number one: breaking the bad news is a simple and easy case. Breaking the bad news is always coming in exam. Breaking the bad news is for chronic progressive illness or cancer. Chronic bad news could be related to genetic illness. Before breaking the bad news, you have to prepare the patient. Preparing the patient, we have to take a consent for discussion with the patient. We have 4 to 5 questions we have to ask the patient about it. First one, how do you feel now? How much you know about your illness? This is the second one. Third one, do you know why we requested this investigation for you? Fourth question, what's your expectation about the illness? Then warning shot. You have to give the patient the warning shot by simple, easy, clearly sentence. By saying, I am sorry to inform you, the result released for us today, and the result is not as we hoped. And you have to keep silent for a second. After you finish the warning shot, another message, ask the patient, do you want to know everything about your illness? Then inform the patient about the management plan, and don't forget multidisciplinary team. Again, don't forget multidisciplinary team. Don't forget multidisciplinary team. Write it please in your hand. Don't forget multidisciplinary team. Say it before starting of the management. Say it before starting of the management. Say it before starting of the management. I repeat it 3 times. Okay? Management plan should include pharmacological and non-pharmacological management. You have to ask the patient about his concern. Please don't forget pre-morbid state. Please don't forget social history, job and job and with whom his live and the past history of medical illness. Maybe it is related to the cause of the illness, or the illness will affect his job. In the discussion, salary, seek understanding and help, and last thing, please offer for the patient anyone to drive him to the home if he needs that. Advanced directive and reason when we have to ask it after we finish social history in last step in the communication. We have to ask it after we finish his job. What's your job? Do you smoke? Who's taking care of whom in the home or with whom you live? We have to do any other advanced directive we're reading going. So this is a summary of breaking bad news. Finally, I hope that this pathway and this lecture make breaking bad news like an ice cream. You can eat it and enjoy it. So take this boat please and go through the ocean. Don't go through the sea. Go deep and deep and deep and find more and more cases and practice more and more cases in the breaking bad news, and you will get more and more information, and at the same time your practice will be improved with the time. Listen to this lecture alone, it is not a solution for the problem. Listen to lecture is one part, but the remaining 9 part out of this 10 parts is practice, 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 practice to 9. Practice is the only step that if you did it well, you will pass. Practice by your tongue, not by listening to others during the practice. Now, I will express again about my deepest thankful for Dr. Khatib, as I am always submit for him lecture at night, and he start working on it to put it in the social media for others. Thank you. Assalamu alaikum. Our lecture today we are going to speak about end of life care. End of life care, one of the hot topics that you may be encountered for it in exam. You can face it with a lot of scenarios, and there is an ethical dilemma. Maybe you will face it. So give me your full attention for the next hour. It is only 1 hour. We will discuss here the introduction about end of life care. End of life care, the patient may be asked you, please doctor, could you sedate me? Or he may ask, could you resuscitate me? Or he may tell you, doctor, can you give me medication to end of my life? Or please doctor, allow me to go home to die. Or maybe this patient is sensitive too much and he will tell you, please don't tell my family I am dying. Or the patient tell you, feed me until the end. Or he can say by other words, I don't want morphine. There is a lot of things could be raised during the discussion with the patient about end of life care. So that end-of-life care is one of the difficult scenarios in the exam because you are dealing with the patient in two ways. One is this way you are going to speak with him about the diagnosis, and at the same time you will tell him your case is no treatment and no curable, it is not a curable disease. So that it is very difficult to deal with such cases in the exam, and most of the time the patient may be angry or the patient may be feel frustrated about the new diagnosis. So that you are like a man who has to cross the bridge between two mountains, and he sit on the other side and want to cross this bridge, and the bridge is fragile, so that you are going to pass, but maybe you will fall from this bridge, and there is two examiner is waiting you at the other side, and they looking from above their glasses. As usual, they drink a lot of coffee outside, and you also at the last night you drink a lot of Indral. So that you have to deal in a sensitive way to cross this bridge and reach to the other side to both examiner to satisfy them. Without dealing in the end-of-life care in sensitive way, you may be lost a lot of marks, and at the same time you may not satisfy your examiner. Let's go and see what is the content of end-of-life care. End-of-life care, maybe you will encounter in the exam one case, it's called don't attend resuscitation order. We usually say DNR. Or patient has chronic obstructive pulmonary disease, and this patient is candid or not candid for ventilation. Or young person or father or mother of the surrogate has a brain stimulus. Also organ donation, one of the most common cases in the exam. Patient has a lot of comorbid illness, and the decision is to withdraw the treatment or withholding the treatment. Post-mortem examination, either this referral to the coroner or hospital post-mortem examination. And palliative treatment. For the patient DNR or ventilate or not ventilate, or the patient brain stimulus waiting for organ donation, withdrawal or withholding treatment, all of above this I mentioned need palliative treatment. So palliative treatment is one of the hot topics that sharing in a lot of cases in the exam. And nowadays they ask about palliative treatment, and what is the meaning behind palliative treatment, and what is the content of the palliative treatment. Now we are going to clarify some terms. Again please, this lecture is too tough and it's too hard because there is a lot of new terms, you have to know it, and a lot of pathways and discussion and the ethical dilemma also in the end-of-life care. We have to clarify some terms. What is meaning by end-of-life care? End of life care, the patient living with the condition. They may die from it in weeks, months, or years. Patient with advanced disease. Maybe three types of patient. Patient has cancer, organ failure, or demented patients. This end of life care. End of life care means that patient living with condition, they may die from it in weeks or months or year. Patient has advanced disease. Patient has cancer or organ failure. Second term is supportive care. Supportive care means helping the patient and the family cope better with their illness. It is not related to disease or time. Supportive care again means help this patient and his family to cope better with their illness. It is not related to which is disease and what is the time when start supportive care. Palliative care. Palliative care, it is physical, psychological, social and spiritual assessment. It has to be generalized and specialized palliative care. Terminal care is diagnosis, dying care in last hours and days of life. So that we have to know which term and what is meaning by this term. End of life care, this patient living with the condition that they may die from it within weeks or months or years. Supportive care means we are coping with the disease and educate the patient and the family how to cope better with the illness. It is not related to the disease or not related to the specific time. Palliative care. Palliative care, again, because maybe someone come late and we didn't listen to from the start. Palliative care means physical, psychological, social and spiritual assessment. Terminal care means diagnosis, dying care in the last hours and days of life. This is the terms, you have to know it. Because if the examiner asked you what is meaning by palliative care, you have to reply. We are professional, so that we have to know exactly what is meaning by palliative care and don't feel unconfident. You are confident and professional. Supportive care, no relation to the time of the specific of the disease. Terminal care, it is dying patient. End of life care, we defined it, patient living with the condition that may die from it within weeks or months. So now we have to go to the end of life care. Before we start end of life care, we have to know palliative care. Because palliative care is showing in doing ventilate or not ventilate, organ donation, brain stem death, and the patient is going to die. Also, we have to know there is a wisdom said that a good death for all. Our aim in the medicine and our aim as a physician is that every person should be able to live well and also die well in the place and in the manner of their choosing. Again, our aim is every person should be able to live well and die well in the place and in the manner of their choosing. But how? How can we go This patient has to die well without loss of his dignity. This we are called palliative care. Palliative care, that is mean the patient has to die well without loss of his dignity. There is an ethical dilemma between palliative care, when we have to start it, and for which patient. Palliative and supportive care, it is different totally in their philosophy from the curative strategy. Palliative and supportive care is focusing primarily on the consequence of the disease rather than the cause or the curable of the disease. So that palliative care, it is focused on the consequence of the disease, not in the cause or a specific treatment. So that we have to know a lot of palliative care. Are you with me? Please concentrate. Take deep breath and concentrate with me. Don't look in your mobile. Let it now and close it. We are speaking about palliative care now. How can we define the palliative care? The examiner asked you what is meant by palliative care, and a lot of candidates already this question faced it in the exam. And it's one told me treat the pain, one treating the symptoms, but you have to define. You are a good doctor, so that you have to know the definition well. The World Health Organization defines palliative care as palliative care, it is approach that improves the quality of life of patients and their family facing the problem associated with life-threatening illness. So that we have to define, yes, palliative care means improve the quality of life of patients and their family facing problem associated with life-threatening illness. Through what? Through the prevention and relief of suffering by means of the early identification and assessment and treatment of pain and other problems like physical, psychological, and spiritual. Again, if the examiner asked you what is meaning by palliative care, you have to define for him. Palliative care means improve the quality of life of the patient and the family, so that it is not only for patient. So the palliative care, we have two tasks, one for the family and one for the patient. Okay, and to early identification of physical and psychological and spiritual needs. This is short sentence. Palliative care, it is different than traditional care in that palliative care, it is typically doesn't rely heavily on invasive test or procedure or other diagnostic method that are aimed at the finding the cause or specific medical treatment. So that palliative care, it is not rely on the invasive process or treatment. It is rely on the consequence of the disease. Again, because we are excellent, so that we have to repeat again. I think you can take this record in a flash memory and put it in your card and listen it every now and then. I think it is good. You receive well. So that what is meaning by palliative care? Palliative care, it is improve the quality of life of patient and their family and early identification of the patient and the family needs. That is good. It is very good now. So that forget what I said. It is improve the quality of patient and the family and identify their needs. One statement. What is the needs? It is physical, psychological, and spiritual needs. Dr. Khatib will take a snapshot for this sentence. Again, I will repeat it again. Improve the quality of life for the patient and the family, and early identification of physical and psychological and spiritual need. That is the definition of the palliative care. Palliative care, it relies on, or it is palliative care, it's specific for the consequence of the disease, not the cause or the treatment. What is the objective of palliative care? We have to know the principle of palliative care. We have to know the goal of palliative care. We have to describe the common physical, psychological symptoms at the end of life and the way to address them using a palliative care approach. Describe ways to recognize the final hour and how best to support family and staff, including spiritual and cultural consideration. This is the objective of palliative care. We have to understand what is the principle of palliative care, and we said the principle of palliative care to focus on the consequence of the disease, not the cause or treatment. You have to understand the goals of care, and we will explain this later. And you have to describe what is the common symptoms and physical and psychological and spiritual needs. Who provides palliative care? Who is responsible about palliative care? It is important that a member of the care team be supportive of the care plan that focus on palliative care. That palliative care is responsibility for all team looking for the patient. Responsibility for doctor, for nurse, for social worker, for dietitian, for health educator, for clinical nurse, for physiotherapist, for dietitian therapy. So that all person sharing in the care of the patient that is responsible, they are responsible about palliative care. If some members of the care team don't agree on the palliative approach, it will be challenging for the other member to fully deliver palliative care. So palliative care is one of the interdisciplinary team management. I think Dr. Khatib making a small videos about multidisciplinary team management. Here, palliative care also is one of the interdisciplinary or multidisciplinary team management. Because the palliative care, it is not just medical or nursing care, it is best implemented using a team approach. It is not medical or only nursing. It is social and dietitian, and each member of the team have a role in the palliative care. What about developing palliative plan of care? All multidisciplinary team have to agree about this plan. We have to make goals. We have to identify physical symptoms and psychological symptoms also. What is the spiritual need and the family need and concern? We have to define the goal of care, which should be determined with significant family and resident input to extend possible causes and possible management plan. We are going now about the addressing the goal of care. If the patient is going to die, or we are considering management plan is a palliative care, we have to hold a meeting with the family if the patient lacks capacity, or with the patient if the patient has capacity. So that put in your mind why I explained from the start Mental Capacity Act, because this Mental Capacity Act, it is the title, and all of physical issue and communication, it is a subtitle in it. We have to clarify to the patient or the family palliative care doesn't mean withdrawal care. And during the explanation to the family, we have to focus on what will be done, not what will be removed. This is very important and sensitive issue. When you are going to speak with the patient or family about palliative care, please don't tell them what we will not do. You have to focus what will be done, so that we will not go in confrontation with the patient or family. So that one of the most important issue in the palliative care, we have to focus on what will be done, not what will be removed. If we are speaking with the patient, we have to know advanced directive. To ask the patient, do you have any advanced directive or living will? We are going to tell him we are updating each now and then the palliative care treatment according to the condition of the patient. Again, this is very important, and I will give an example during the discussion now. We have to focus and clarify on palliative care doesn't mean withdrawal of treatment or withholding the treatment. During the discussion with the family or with the patient, we have to focus on what we are going to do for him, not what we will be removed. If we are going to discuss with the patient, we have to ask him about advanced directive or living will. What is the symptoms the patient may be faced at end of life care? The commonest symptoms is pain. Maybe the patient has shortness of breath or cough or wheeze. Or maybe this patient has some gastrointestinal symptoms. Maybe this patient feels depressed or anxious, so that we have to know and tell the patient or the surrogate or relative, we will not allow you to feel any pain. If you have any pain at any time, please tell us and we will submit the new medication. And this medication will help you and allow you not suffering from pain at all. And we can titrate the dose of medication to avoid any pain during the course of treatment. And also, if you have any constipation, because some patient of end of life care has most common constipation than diarrhea, because the patient is bedridden and not eating well. And also for any psychological problem, we can offer for him psychological support. So that the common symptoms at end of life care is pain, constipation, and psychological problem. Next thing, we have to address the spiritual needs for the patient. Please don't wait until the last minute and speak in the palliative care. For each patient, we have to raise the issue of spiritual need, so that we can tell him, if you need any help from other people have the same religious, we can contact them and support you. So that we don't wait until last minute, or don't wait until the patient die before addressing spiritual need. It is very important issue, and if you put it in your mind and you ask the patient about it in the exam, definitely you will get the full mark, because a lot of candidates didn't raise this issue in the exam. So that spiritual need, you are going to tell the patient, if you need any help from your religious advisor, they can contact him and arrange a meeting with you. Culture considerations. We are different in culture and different races and lifestyle and values and beliefs, so that we have to ask the patient, do you want any specific thing? We can arrange it for you. Do you have any beliefs or values you want it in the coming days? This is the most important issue. So that palliative care means physically, like symptoms, pain, control, gastrointestinal symptoms control, and psychological symptoms control. And also means spiritual needs, we have to raise this issue, and the cultural needs, we have to raise it. So that, again, I will define the palliative care in the form of, it is specific for the consequence of the disease, not in the cause or in the treatment for the disease itself. We have physical, psychological, social, spiritual, and cultural considerations. We have to preserve the person and dignity of the patient. It is one of the most important aspects of the palliative care to focus on the dignity of the patient. It is responsibility of all members of the team to preserve the dignity. But we have to keep the patient clean and bathing, and we have to take mouth care and clothing care and bed care also. At the same time, we have to allow this patient feel free from any pain or any distress. So that we have to clean the patient, clean his mouth and his nails and his face, and keeping him in a good manner with good clothes and good bedding. All of this is the palliative care. So that if we are going now to define the palliative care and give the summary of the palliative care, again, palliative care, it is one of the important issues. We have to discuss it with the patient with end of life care, and we define what's meant by end of life care. Palliative care means focus and identify the early needs of the patient physically, psychologically, and spiritually. Palliative care, we have to control the symptoms, and we have to raise the issue of the spiritual need, and also we have to raise the issue of the culture and the values and the beliefs, and keep the patient personhood and dignity worth of all time. So that I will give an example. If the patient, you told him that you have cancer and there is no treatment and only palliative treatment, don't tell the patient palliative treatment only. You have to tell him what's meant by palliative treatment. Palliative treatment means we control the symptoms related to your illness. If you have pain at any time, we will give you painkiller. And these pain drugs, we can modify it each now and then according to your pain score level. And if you feel any other symptoms like heart disease, tell us, we'll have a medication for it. If you have any change in your mood or you feel low mood, we can allow one person to share with you some information. This is called psychologist. Also, if you want any advising from your religious advisor, you can contact them and give you a meeting with him to discuss some issue related to your religious factors. Also, if you have any values and beliefs, you can tell us that free. You can tell us freely, and don't hesitate to ask us, and we will provide for you each information you want or each thing you want regarding your values and beliefs. This is if you are speaking with the patient. The same also if you are going to speak with the relative, but you have to add, you will keep your father or your mother, it is in a good shape most all times. We will take care of his knees and mouth and his clothes and his bathing. All the team are responsible about provide this palliative care. This is what's meaning by palliative care, and for whom we provide this palliative care, and how can we apply the palliative care. Last thing in the palliative care, I would like to say, palliative care should start with the patient once he is diagnosed, not before this. Again, palliative care should start once we diagnose this patient has a critical illness or cancer, not after treatment. It is started with the same way of the treatment, because as I said, palliative care, you are concentrate on the consequence of the disease, not on the disease itself. This is palliative care. And I think all of us now know what's meaning by palliative care, what's the goals of palliative care, and who is responsible about palliative care, and what's the content of the palliative care, and what is the spiritual and cultural needs. Today we are going in the next session also, and in the same lecture we are going to speak about one of the end of life care. Stop please, don't resuscitate. This is the issue we will discuss today. What is meaning by don't resuscitate, or DNAR. Don't resuscitate means you will not do resuscitation for the patient. Why? Before we speak about DNR, we have to know what's meaning by CPR. Now we are going to do for the patient CPR. First we have to know what is the aim of the CPR. Aim of the medicine is to restore and maintain and prolong life with maximum benefit and minimum harm. This is the aim of the medicine, is to restore, maintain and prolong life with maximum benefit and minimum harm. Continuing or providing with a treatment is not justified if it is increase the risk. So that our aim of any treatment to maintain and prolong life with maximum benefit and minimum harm. But if the harm is more, we will not provide this treatment. In some cases, prolonging life can increase the burden of treatment and of the underlying disease condition. This is the aim of CPR. So that if you are going to kill the patient or the surrogate, you are not resuscitate him. After explanation of his illness, tell him what do you think about the future of your illness. If you speaking to the patient, you have to ask the patient. Don't tell him we are not resuscitate you. Ask him about first, what do you think about your illness? After I explained to you your illness, what do you think about it? Or how can you see the outlook of your illness in your mind? So that you have to explore the patient, what is running in his mind. Maybe the patient feels that the treatment is futile, or he will not get any benefit from the treatment. So that you have to say to him at this time, yes, I can tell you that the treatment, we will give you treatment, but if your heart or your breathing is stopped, I am sorry to say we will not start resuscitation for you. And ask him after that, what do you know what's mean by resuscitation, and I will explain that. So that you have to tell the patient, now what do you think about your illness? Then you have to tell him, in medication we start it if it is maintain and prolong life with maximum benefit and less harm. And if we find this medication it is cause more risk than benefit, we will not provide it for the patient. This is before you start to tell him not for resuscitation. First you will ask the patient, what do you think about your illness? Then you will tell him the aim of the treatment is to restore and maintain and prolong life with maximum benefit and a little harm or minimum harm. So that the aim of CPR to restore breathing and spontaneous circulation. This is relatively invasive treatment and consists of chest compression. This is the definition of CPR. Electrical shock, injection of drugs, ventilation of both lungs. This may be followed by period of monitoring in intensive care unit or coronary care unit. Some patients may require mechanical ventilation, electronic support, renal support, and other form of invasive treatment. This is the definition of cardiopulmonary resuscitation. So that you will tell the patient, as we agreed, what do you think? And next question, to define for him what is the aim of treatment as a general, and tell the patient what do you think if your heart is stopped, and then tell him what is meaning by resuscitation. Resuscitation means it is consists of chest compression, maybe electrical shock, injection of the drug, and the ventilation of the lung. Some patient needs mechanical ventilation, electronic support, renal support, don't really electronic support, some medication to support the heart and the kidneys, and maybe need specific invasive treatment. This is the definition of CPR. Take the breath please. Wake up. Give me your attention. Today no coffee at all, only on the round today. The aim of CPR is to restore breathing with maximum benefit and little harm. Content of CPR: chest compression, maybe electrical shock, injection of drugs, ventilation of lungs, maybe the patient need mechanical ventilation, drugs to support the heart and the kidneys. This is the definition of CPR. At the same time, we have to know the complication of CBR. The complication of CBR may be you have foot fracture. Maybe due to prolonged CBR, it will be irreversible brain damage. Maybe injury to some organs like liver, spleen, or collection of the air around the lung. It's called pneumothorax. So that I'm going to give an example now, complete example. Yes. Give me space, please. Now I am going to discuss that this patient has cancer, and this patient not for resuscitation. He has cancer and metastasis, and the decision this patient is not for resuscitation. After I explained to his family what is meaning by cancer and metastasis, and will start for him palliative care, or I will explain. Then I will go to her CBR. I will ask the family, after I explained to you the cause of your father's illness and the consequence of his disease, what do you think about the outlook of your father's condition? Yes, doctor. I feel that this primary disease affects a lot of organs, and there is a lot of things has been affected in his body. Yes, Mr. Hassan. Could you tell me if your father has any advanced directive on living well? No, he doesn't have. If your father has any expression or wishes about his illness when he in such situation? No, doctor, he doesn't express for me anything about that. Did your father appointed anyone to take a decision on behalf of him when he in such situation? No, doctor, he didn't appointed anyone. Let to tell you, Mr. Hassan, and I am sorry to tell you that your father has a cancer, as I told you, and this cancer not only in his liver, but it's spread outside the liver. It's now in the bones and in the bones and his lung. So that the team looking after him took a decision. Your father, it is not for resuscitation. Do you know what's meaning by resuscitation? No, doctor, what's meaning by resuscitation? Let me first to explain. The A treatment we provide for the patient is to maintain and prolong his life. And prolong his life, it will give a benefit for patient more than the risk. The aim of any treatment. But if we find any treatment will provide for the patient a lot of risk and no benefit, we will not give the patient this medication. This is our aim in the treatment and our aim in medicine. Secondly, I am meaning by resuscitation. Resuscitation is when the heart or the lung is stopped. For any patient, we will start from chest compression, and maybe need to put a tube to assist his ventilation in the most lung, and may also to give electrical shock for the heart, or give medication through a needle. This is resuscitation. But in some cases we found this resuscitation is not helpful, and there is a lot of risk for it. So that if I outweigh the benefit and the risk of this resuscitation for your father, I am sorry to say that the resuscitation is not helpful for your father at all, because resuscitation maybe will prolong your father's life for some times, but there is a lot of risk, and your father maybe he will pass away in undignified manner. There is a lot of complications related to this resuscitation. One of these complications, as we provide chest compression for your father, he may develop breath fractures, this bone in the chest, and maybe develop some air around the lung, and maybe this connection of air will need also to insert a tube in the lung. Sometimes resuscitation may be prolonged, and so that the oxygen to the brain will be decreased and maybe develop irreversible brain damage. Maybe there is some injuries related to other organ like liver and spleen. So that if outweigh this complication that may be happen to your father and the benefits of the resuscitation, we found that the resuscitation is futile. I am sorry to say that. What do you think, Mr. Hassan, about this? So that you have to explain to the patient first what is the aim of our treatment, what is meaning by resuscitation, and what is the complication of resuscitation, and why we will not consider resuscitation for his father. Before this, you have to ask about advanced directive, breathing oil, patient wishes, and the last power attorney, and we told a lot about that in the lecture of Mental Capacity Act. This is the issue of don't attempt resuscitation. Who is responsible to make a decision this patient is not for CPR? The responsibility to make CPR to senior clinician or other member of the staff that on the charge on behalf of him. This decision should be based on clinical assessment and patient circumstances. Sometimes, maybe the team looking after for patient take a decision this patient is not for resuscitation. But after revising that, we found that this patient need for resuscitation, so that the order for resuscitation is not for life. It could be revised again and could be updated if we feel the resuscitation will be helpful for the patient. There is a rule. This rule we have to put in our mind, and it will solve a lot of ethical dilemma in your brain. This rule says that neither patient nor their relative can demand CPR or any other treatment when the clinical team believes that CPR will not be successful. We have to explain to the patient or family in sensitive way and why CPR is not successful. So that if the family member of the patient told you that, doctor, I need to do for my father resuscitation, so that you have to explain why this resuscitation is not successful, why this resuscitation is futile, what is the complication could happen to your father. Even your father has a success in CPR, he will not take more than 1 or 2 days, and this his heart will stop again. The patient family has the right to take second opinion. We have to clarify this information. If the patient doctor, if the team looking after for the patient doesn't agree with the family wishes for CPR, like the family refuse the decision of not for resuscitation, the family not agree about the decision if the patient is not for resuscitation, and the team looking after for the patient is take a decision this patient is not for resuscitation, so that we can take second opinion. If still there is disagreement, we have to go to legal advice may be required. Again, if there is any confrontation between you and the family, you have to make a second opinion, or you can say, I will arrange a meeting with my consultant. If the examiner asked you if still disagreement between your consultant and the family, we can take a second opinion. If still disagreement, we will go to legal advice. The CPR is given to patient has cardiac or respiratory arrest to prolong life. As we said, CPR contains ventilation of both lung, electrical therapy, injection of drugs, and decompression. Always know DNR don't resuscitate order. This legal order would tell a medical team not to perform CPR on a patient. However, this doesn't affect other medical treatment. It is very important, this last statement. Last statement, we can summarize it in the next slide. Don't resuscitate doesn't mean don't treat. One of the important information you have to convey it straightforward and to be confident when you're going to say it to the patient. Don't resuscitate doesn't mean don't treat. So that if you are going to speak to the family, this resuscitation order is not allowed for your father. But it doesn't mean we will not treat him. We will treat him and continuous looking for him for the medical treatment. But this resuscitation order only if his heart or his lung function is stopped, so that we will not resuscitate him. If the patient still alive, we have to, or the patient has capacity, we have to speak with him about the DNR order. And the patient can sign this DNR order, and we will tell him we will revise this DNR order later. And if we feel that there is some changes happened, we will discontinue the order according to the medical decision. So that the DNR can be cancelled by the medical team, but be sensitive. If you have patient has cancer and this patient has multiple metastasis, so that no way, it's only palliative treatment. So that don't tell him we can cancel the order of DNR. One question is, DNR form of advance directive? Yes. If the patient sign DNR form, so that it is one of the advanced directives. One patient has chronic obstructive pulmonary disease and he make advanced directive, he doesn't need to be resuscitated, so that we have to follow it. It is one of the advanced directive. Should be specified. Does every patient have CPR? If the patient has cardiac or respiratory arrest, we have to start CPR for him, unless the patient is specified refuse this therapy in advance through advanced directive. There will be some patients for which CPR will be inappropriate, like final stage of disease like cancer will not be successful. So that each patient has cardiac arrest or each patient has respiratory arrest we have to consider this patient is for CPR unless he has advanced directive or this patient has terminal disease. Again, the rule is neither patient nor relative can demand treatment which is clinically inappropriate to them. Nor the patient or his family can demand any treatment if it is against the medical decision. people want to drink tea, yes, we can go together and make a cup of tea to concentrate well. Again, neither patient nor relative can demand treatment which is clinical inappropriate. Neither doctor nor candidate can demand a cup of tea which is clinically not support his brain during this lecture. I prefer to drink tea now. We are now almost 3 a.m. No need to drink coffee, so that if I drink coffee now, I will not sleep well. Can the NAR be suspended? If we take a decision or the patient right need, he doesn't need to be resuscitated, and it is registered and it is advanced directive or living well. Can we hold this for sometimes? Yes. For some patients on DNR order, they may develop cardiac or respiratory arrest through reversible causes like shocking or anaphylaxis, and in this situation CPR would be appropriate unless the patient has specified issues treatment in such cases. So that during getting the DNR order, we have to ask the patient if we find that there is some reversible causes for that cause of cardiac arrest. Can we suspend the DNR? Some patient also has written DNR order, and they are going to do a procedure to have, maybe this patient will develop cardiac or respiratory arrest. Maybe this patient has surgical operation. DNR may be temporarily suspend on discussion with patient, so that this it will not face, you will not face it in the exam, but also maybe the examiner will ask you, can DNR be suspended? Yes, doctor, it can be suspended if the patient has a reversible cause of cardiac and respiratory arrest. But first of all, we have to inform the patient about that and take his consent if in the advanced directive to specify if he has any reversible cause of cardiac arrest. We will go through CPR or not, so that we have to specify, or the patient has to specify the reversible cause of cardiac arrest in the advanced directive, or also if the patient arrest during the surgery or cardiac catheterization. Should patient always be informed about DNR? Yes. When we are going to discuss with patient about the DNR, we have to inform him, do you want, as the breaking bad news, do you want to know anything about, do you want to know more details about the future plan for you? And at that we have to inform him about the DNR in a sensitive way. If you have patient now, he has cancer and in palliative treatment, don't raise the issue of DNR if it is not mentioned in your task. So that for the second paragraph here, for some patients who are approaching the end of life, informing them about the DNR order would be of little or no value. Clinician should document the reason why a patient hasn't been informed of DNR order, as they may be asked to justifying their decision. This is especially the case of patients where they have indicated a clear desire to avoid such discussions. For the second paragraph, if in your exam this patient has cancer and has metastasis and the treatment is only for palliative care, don't give the patient, you are not resuscitate him. It is not in your task, it is not written in your task, so that don't raise this issue. But if it is written, but if it is but if it is written in the task, you have to raise it. Not written, you haven't raised it. If the patient doesn't want to discuss more about the resuscitation, we have to respect his desire. When the patient is having the terminal stage of an illness like cancer, it will be inappropriate to subject the patient to CPR, which may lead to a traumatic or undignified death. In this and similar other conditions, CPR decision should be a part of advanced care planning. It should be documented at all times while the patient hasn't been informed of the DNR order. Again, discussion CPR with the patient having the terminal illness. Only will raise this issue if it is written in the scenario. But if it is not written, we will not discuss it. If the patient asked me if my heart stopped, are you going to resuscitate me? We have to answer this question, no need for resuscitation, by the similar way that we are discussed before. So that discussion of CPR with the patient, we have to raise it if it is mentioned in the scenario, or if the patient asks me clearly if my heart or my lung stop, how can we deal with it? If it is not written in scenario, so that we will not raise it at all. And if the examiner asked why you didn't raise this issue, we will tell the examiner that this information have a shock for patient also, and we can give a two breaking values in one session, and maybe in the next meeting I will tell him about that if it is raised by him. If the patient lacking capacity, again you will find the mental capacity act in your way. If you go through the open street or closed street or narrow way or wide way, you will find the mental capacity act with you. So that I prefer to put mental capacity act in your handbag or use it in your daily activity, like you're using the social networks. What happens if the patient lacks capacity? Patient undergoing cardiac and respiratory arrest will lack capacity. However, if the patient has valid advance directive, can be set in place for this occurrence. So that if the patient lacks capacity and his advance directive and even when he doesn't need to be resuscitated, we have to follow the patient. The patient has capacity, he can refuse CPR in advance without any justification to their decision. If the patient lacks capacity and this patient has advanced directive, you have to follow it. If the patient doesn't have capacity and he has appointed a last power attorney who has the authority to make a clinical decision, and it is specified in the document of last power attorney, he can take a decision for life-saving medication, we will follow the last power attorney. What if a patient doesn't have an advance directive or last power attorney and he is lack capacity? If a patient hasn't created advance directive or last power attorney, family and friends may be consulted about the DNR. However, the final decision rests with the most senior consultant in charge of patient. If no family or friends, the physician can consult the independent mental capacity advocate, IMCA. If the patient doesn't have any advanced directive and last power attorney and he lacks capacity, we can consult his family to know his wishes. And if he doesn't have any family or advanced directive or last power attorney, we will go through the IMCA. If the patient come to emergency department and he doesn't have any advanced decision, CPR should be attempted unless the patient has refused CPR or he has advanced directive that said he doesn't need to be resuscitated if his heart or his lung stopped. Does the DNR apply to CPR only? Yes. DNR only applied to CPR. Again, DNR only applied to CPR, and it doesn't apply to another aspect like biopsy, dialysis, ventilations, or other aspect of treatment should be continued. DNR only for CPR. If the patient has COPD and has COPD exacerbation, are you going to ventilate him or not? Yes, I have to ventilate him. But if his heart stops, I will not resuscitate him. So that ventilation is a part of CPR, so that if the patient has advanced directive no need CPR, but he has COPD with exacerbation or pneumonia and he need to be ventilated, yes, I can ventilate him. But if his heart stops, I will not resuscitate him. This is the ethical dilemma that we discussed today about palliative treatment and about the don't resuscitate. I used to do in the previous lecture, I will go in the summary because some person now don't concentrate well, and maybe some persons or some candidates was playing in their mobile or looking for a message or they have a call or they thinking in their basis exam or maybe they slept during listen to my lecture. That I will go again in summary for end of life care. Today we discussed palliative care. Palliative care means we are looking for the consequence of disease, not on the treatment of the disease, and we have to identify early the patient and the family needs for physically, socially, spiritually, and values and beliefs of the family and the patient. So palliative care, it is dealing with the patient and the family and identifying early the physically and psychologically and social and spiritual need for both. The responsibility of the palliative care, it is for all team members, not for only physician or nursing. It is for doctor, for nursing, for dietitian, for physiotherapy, for social worker. Palliative treatment, it is a symptomatic treatment for pain, gastrointestinal symptoms, maybe need psychological support for the patient if he has depression. Spiritual need, we have to discuss is with the patient or the family if they need any help from advisor have the same religious. Beliefs and value, we have to discuss it with the patient and family. This is the palliative care. If I am going to discuss the case of palliative care with the patient, I will go to say that as I mentioned to you, Mr. Ali, you have cancer in your liver, and this cancer in the liver, it goes so away from your liver and it is now present in the bone and the lung. we are going to treat you by multidisciplinary team. This multidisciplinary team will contain the liver physician and the cancer physician and also social worker. At the same time, the pain management physician will be involved in the team. In this multidisciplinary team, we will treat you in the palliative treatment. Mr. Ali, do you know what's meaning by palliative treatment? No, doctor. Palliative treatment means that we will focus in the consequence of your illness, so that we will deal with your condition and treat you for any symptoms you may develop it. First, if you have any pain, we will treat you with pain medication, and this medication could be titrated till we reach the level control your pain. And if you feel any pain at any time, don't hesitate to tell us about it. If you have any other symptoms like joint pain or hard stool or difficult in bus or difficult to bus to open your bowel, please tell us and you can treat it. Mr. Ali, if you would like to support you and if you feel that low mood, I can take an appointment for the physician that will help you a lot in the difficult time. Also, if you need any help from another person for religious advisor, I can contact one of your religious advisor and arrange for meeting with him. Mr. Ali, do you have any values and beliefs you want it? No, doctor. Yes. Mr. Ali, again, as I told you, this is palliative treatment to control the pain and to control any symptoms you may develop it, and we will take care of you. And if you also, if you need any advisor from your religious, I can contact them. This is the palliative care in summary. For don't resuscitate, as I mentioned, if the patient has capacity or not capacity, first of all, the rule is no one can demand any treatment against the medical team decision. This is the rule. Don't attempt resuscitation. What is meaning by CPR? CPR means chest compression, electrical shock, and medication, maybe lung ventilation, mechanical intubation, and aim of CPR to prolong life with maximum benefit and little harm. The complication of CPR, it is rib fracture, it is connection of the air around the lung, and connection of the air around the lung, and rupture of the spleen, rupture of liver, and burn from the electrical shock. We have to explain the no need for resuscitation in a sensitive way to the patient or to the family. And we will start to explain first what is the aim of the treatment and what is meaning by resuscitation, what is the complication of resuscitation. This is don't attempt resuscitation. So that today we focused in two issues, palliative care and not for resuscitation. I hope this information will be benefit for others and other candidates, and as much as I can I make it more simple. And there is a lot of ethical dilemma in this area, but I defined it and make a short statement for it to know what is meaning by palliative treatment and what is meaning by CPR and when indicated and when not indicated. And I hope we can go through it and listen it many times, and if any person will want any questions or inquiries about this lecture, he can contact us. Again, and each time and each meeting, every meeting, I'm going to thank Dr. Khatib because I will submit all of this information to him and he will upload it in a social media. It is a very great job, and I think Dr. Khatib, you can work in this area and make medicine for other people like us. You are very you are I'm joking with you. You have a lot of experience in this issue, and I am really thankful for your effort. Thank you. See you next time. Hello. We are going to continue our lecture about communication tips. We discussed a lot of scenarios and cases in the past, and we are going today to discuss one of the important issue in the communication. This is called brain stillness. Brain stillness, it is one of the important ethical dilemma. You can face it or encounter it in the exam. Especially in this case, the patient not have capacity, and usually you discuss the case with his relative, and his relative is frustrated from what's happened to the patient. Sometimes this patient is young and he suddenly dead due to maybe motor car accident, maybe due to sudden stroke or hemorrhage. So you will see an angry patient. At the same time you will raise the issue of this, and maybe also you need to raise the issue of organ donation. So that very important to put in your mind, in this patient has brain stillness. It is one of the case in the exam you may feel uncomfortable during discussion, because all time in the scenario you are breaking bad news. You facing a problem with angry patient, then start to breaking bad news, then start to feel a denial from the patient, from the relative, about his son or his father, why he died. Then you start again to breaking bad news and counseling about organ donation. So that what I need from you now, to give me your full attention to what the pathway, as we used to do in the past, pathway for organ donation and brain stillness. First of all, to understand anything in communication, you have to put a rule. This rule will help you if any scenario came to you in the exam, or the scenario has been changed at any time. If you have a rule, so you will feel comfortable if there is any scenario come to you. So that let us to start our discussion today and our lecture about brain stillness and organ donation. Give me your full attention, please. First, we have to know what definition of this. At which time you can tell the relative this patient has been died. In spite of, in front of the relative, the patient breathes using the machine and his heart rhythm is continuous on the monitor. So let us first to know what mean by this. Usually the this is defined by number 1, irreversible loss of capacity for consciousness together with irreversible loss of capacity to breathe due to cessation of the brain stem function. So that you have two irreversible. Number one, irreversible loss of capacity for consciousness. Number two, irreversible loss of capacity to breathe due to cessation of brain stem function. This is the definition of this. So that we have two irreversible that we have to depend on the definition or decided this patient has brain stem death. If the brain stem is damaged, the centers that control breathing and circulation fail and patient could be die. How can we diagnose brain stem death? There is a rule of 2+1. Please give me your attention. There is a rule of 2+1. Number one, two doctors. This now. Two doctors registered for at least 2 years, competent in their field, not members of transplant team. يبقى at least 2. We said now a rule of 2+1. This is one of the rule. 2 doctors registered for 2 years. Okay? Have to check the patient twice, 2 different occasions. 2 doctors registered for 2 years and check the patient twice. At least for these 2 doctors, one is a consultant. Yes, a rule of 2+2+1. 2 doctors registered for 2 years and one of them is a consultant and check the patient and they check the patient in 2 different occasions. So that to confirm the death and brain stem death, it is one of the difficult scenario as I said in the exam. Why? Because once the brain stem has stopped the function, there is no way to revising the heart and breathing automatically, so that the patient will be continue in ventilation, and sooner or later this patient will be die in the recent futures. What is the clinical diagnosis for brain stem death? Actually, in the exam, you will not tell the patient all of this information related to definition of the brain stem death, but your examiner could ask you in the discussion what is the clinical diagnosis. You will depend on it to diagnose the case as a brain stem death. First, absent brain stem reflex. We have pupillary reflex, corneal reflex, and vestibulo-ocular reflex, or equinocephalic or gag reflex. So number one, it is absent of the brain stem reflex. Number two, absent of motor reflex of cranial nerves, like swallowing, like movement. Number three, there is no respiratory movement occurs when patient disconnect from ventilation. If we stop ventilation, the patient will not continue breathing. Number four, persistent apnea. When we disconnect the patient from ventilation, the apnea will continue and carbon monoxide will increase more than 6.6. If patient doesn't try to breathe again once the ventilation has been discontinued, and hypoxia should be prevented by delivering oxygen at 6 liters per minute. We will stop ventilation, we will check the patient response, the patient there is no any respiratory movement, even though the carbon monoxide will increase. At this time we have to support the patient oxygen by 6 liters per minute. Number 5, there is no reversible cause could be the cause of this, like hypokalemia, hypothermia, the patient taking drug overdose like antidepressant. So that this is the brainstem death. How can we define it, and how can you diagnose it? The next slide will speak about what is the protocol of the brainstem death. Brainstem death, it is one of the breaking bad news. So that during the discussion of the brainstem death, we have to follow the protocol of breaking bad news that we discussed before in one lecture. There is an example now. One patient had motor car accident and he came to emergency room and was assessed by physician. He is unconscious and there is difficulty to breathe. You insert a plastic tube to help his breathing. So that this one of the scenario. When this scenario came to you in the exam to tell the relative this patient has brainstem death, you are going to say, after introduction, already will not speak about it, you will ask the relative how much you know about your son illness. Then what's your expectation, or how much information you have been told about your son illness. Then starts the scenario analysis. As you know, Mr. Muhammad, your son came to emergency room after motor car accident and he was assessed by physicians. These physicians include emergency room doctor and intensive care doctor and brain doctor. At this time, your son he is unconscious and there is difficulty to breathe alone. We helped him by introducing a plastic tube to help breathing and put him in a machine, and we transferred him to the radiology imaging department, and there is an image has been done for him and showed that your son has a massive hemorrhage. I am sorry to say that for you. Then you have to be silent for time. Then complete your speaking. After this image, we transferred your son to intensive care unit, and also there is a second assessment done by the consultant of intensive care unit and the brain physician. They did a lot for test for him to check his response and check his brain function. Unfortunately, his condition is getting worse and there is no any sign of improvement. I am sorry to say that for you. At this time, the relative will ask you, what do you mean by that? Then complete your speaking. We did function of the brain, and there is one organ inside the brain. It is called one function unit inside the brain. It is called brainstem. This unit, it is its responsibility to do function of breathing, heart, and movement. A lot of center inside the brain is controlled by this area. It's called brainstem death. I am sorry to say for you, this brainstem death is responsible to regulate everything, and if the function of this area has been stopped, it will affect the breathing, heartbeat, and blood pressure. After brainstem death, this area will not function well, and the brain physician and intensive care physician did function for this area. Unfortunately, they found that the brain is technically dead. I am sorry to say that for you. They'll absorb the patient and wait for his response. After brainstem death, it is not possible for someone to remain conscious, and this cell, once it is dead, it will not recover again. I am sorry to say it is mean this irreversible brain damage. Then absorb the patient. Maybe the surrogate asks you if he is breathing and his heart is beating. How can he do, doctor? Your answer will be, I am sorry to say that your son or your father was dependent on a machine to do the breathing for him, and his breathing will be stopped to function if the machine is disconnected. Also, the heart will stop also after that. So that the lung and the heart of your father are maintained on the machine. I am sorry to tell you there is bad news. As I mentioned for you, the brainstem is control everything automatically, and once this cell in the brainstem has been died, it will not come again or recover again. After argument maybe with the relative, he will mention for you a lot of question. How come doctor he is died? I saw him, he is still young, he didn't have any problem before. So that we have to absorb the patient and consider that it's a denial or sense of grave. So that we have to stress about most important point that this patient is technically dead. Because if you tell the patient I will review my examiner again or I will seek for second opinion, it will be a disaster in the exam. So that you have to emphasize the patient is technically dead and the brainstem will not come again or function again, because once the cell is damaged it will not recover again. Maybe the patient will ask you what will happen after that. What will happen? We will stop the machine that helping his lung, and emphasize about that stopping the machine is not the cause of death, as the patient already technically dead. So if we continue, the machine is not going to bring him back again. One of the important answer is that if you tell the patient we will stop the machine, you have to emphasize stopping the machine is not the cause of death, because the patient is already dead. Even we continue the machine, the patient will not come back again. One of the important answer, you have to answer it to the patient. This is the brainstem death. So that a case of a brainstem death, you will follow the protocol of breaking bad news. One of the important issue, you have to emphasize this patient is technically dead and his brain function will not recover again because the cells it's damaged. Even you saw him the breathing, his breathing is maintained by machine or his heart is on the monitor, but the patient is dependent on the machine, and once we disconnect this machine, his heart and his lung will stop soon. And the causing of dying is not to disconnect the patient from the machine, because the patient is already dead. This is the brain stem death in short. Maybe the patient, the examiner will ask you, what is the difference between brain stem death and locked-in syndrome? Locked-in syndrome, it is a state of unresponsible due to massive brain stem infarction. Massive brain stem infarction. The patient has function of cerebral cortex and he is aware but can't move or communicate except by vertical eye movement. I will make it simple thing for you. You have two areas in the brain. Cortex, cerebral cortex, and the brain stem. Cerebral cortex, it is responsible about awareness and some functions of the brain, and this brain stem, it is automatically responsible about the breathing, heart, and the cranial nerve also inside it. So that if there is damage in the brain stem by hemorrhage or severe infection or massive bleeding, so that if this area only affected, it is called locked-in syndrome. And the cerebral cortex is normal. The cerebral cortex is responsible aware of the patient. And brain stem, it is responsible about the movement and communication of the patient. So if you have locked-in syndrome, you have a problem only in your brain stem infarction. Brain stem only. So that the patient is aware, but he can't move or communicate. This is called the locked-in syndrome. But now we have three differential diagnoses: brain stem death, locked-in syndrome, and vegetative state. We have cerebral cortex and the brain stem. In brain stem death, the cerebral cortex and the brain stem both affected. We called brain stem death. If you have locked-in syndrome, the brain stem only affected, so that the patient is aware but can't move or communicate. It's locked-in syndrome. What about persistent vegetative state? Persistent vegetative state, it is damage in the cerebral cortex. As I mentioned now, we have cerebral cortex, brain stem. If both damaged, we have brain stem death. Locked-in syndrome, it is only damage in the brain stem, so that the patient is aware. Persistent vegetative state, it is damaged only in the cortical region. Cerebellar cortex only damaged, so that the patient is not aware. But his breathing is continuously because his brain stem function is well. To diagnose persistent vegetative state, at least 6 to 12 months needed to confirm it is persistent vegetative state. Again, we have three differential diagnoses. Locked-in syndrome, damage only in the brain stem. Persistent vegetative state, damage only in the cortical region. Brain stem death, damage of both. So that if you have damage in the cerebellar cortex only, so that there is damage in the awareness, but the patient can continue breathing. If there is damage in the brain stem only, it's called the locked-in syndrome. If there is damage in the cerebellar cortex and the brain stem, it's called brain stem death. This is persistent vegetative state. At the end of today, I will give a summary for brain stem death and organ donation together, because most of the time both are coming in the same scenario. feel comfortable now? You understand what do you mean by brain syndrome? You understand what do you mean by locked in syndrome? You understand what that mean by persistent vegetative state. Please concentrate with me as I make in the first slide. Give me your full attention. Don't try, please. Don't try to sleep, please. You know now, there is no crime in the world. If you slept during a meeting, you know what will happen. Next, we are going to discuss the organ donation. Organ donation. Organ donation, one of the important ethical dilemma. There is a lot of inquiries running in the brain of the candidate and a lot of questions you ask you about it. So that today I am going to discuss the organ donation by question and answer. What are types of organ donation? We can do organ donation after brain stem death, or after cardiac death, or living organ donation from the living period, from the living people. So that we have three types of organ donation. Maybe after brain stem death, or after cardiac death, or from one person to another person and the donor is living. This is the types of organ donation. What is the benefit of organ donation? Do you think the number have a role in medicine? Yes. Numbers are the great thing. You are going to convince the patient about your procedure or about your treatment. So that from 80 to 90% of kidney will still working after 1 year. It is from cadaveric organ donation. 80 to 90%. 77% will still working after 5 years. And 58% of kidneys still be working after 10 years. So that if you are going to discuss with the patient about and the patient ask you, doctor, after organ donation done for me, what is the suitable period of time my kidneys will be working on? So that you have to know this. From 80 to 90% after 1 year will continue working, and this percentage could be declined to 77% after 5 years and to almost 50% after 10 years. So that the numbers in medicine have a rule. However, if you donate a kidney from living donor, the percentage after 1 year will be 95, still be working after 1 year. In cadaveric, it is from 80 to 90. And after 5 years will be 84. And in cadaveric, it will be 77. And after 10 years, it will be 66. In cadaveric will be 58. So if we make a comparison between living donor and the cadaveric donor, the percentage in the living donor is high, more than the cadaveric donor. So that if you are going to discuss with the patient this, you have to put in your mind, if the patient asked you, my father or my wife will give me the kidney, is there any chance of this of the kidney to be working well? Yes, we have a percentage, so now we can put this percentage or these figures to the patient to give him what is the outcome of our procedure. Donation after brainstem death. The patient always in the critical care unit. First, the brainstem should be confirmed, as we already said. There is no upper age of limit. Only contraindication of the brainstem death this patient has Creutzfeldt disease. Coroner, most important issue, coroner consent may be required prior to donation in special situation, like if the patient came in motor car accident or the patient died in theater, so that the coroner should be obtained. Again, coroner consent, not in your mind, coroner consent. I emphasize about this issue because most of patients came to the exam with motor car accident. In the after brainstem death, you can give heart, lung, livers, pancreas, small bowel. Also tissue donation like cornea and the skin could be available. So that one of the important rule in donation after brainstem death, coroner could have a consent to take a consent from the coroner if this patient need to transfer it to the coroner according to criteria after referring patient to the coroner. Also, the patient we have to donate maybe after cardiac arrest. The death should be confirmed by cardiorespiratory team. All things could be donated, like liver and kidney and pancreas, and also tissue donation is also possible. What are the criteria of organ donation? Number one, the brainstem already died and it's diagnosed and the patient now on ventilator. Number two, there is no blood-borne virus like hepatitis or HIV, no history of malignancy, and no systemic infection. So that is the criteria of organ donation. Patient brainstem died, no history of malignancy or systemic infection, no blood-borne virus. What will happen if the patient has a donor card but the relative refuse donation? If the patient carry a signed donor card, it is like the advanced directive. According to Human Tissue Act 2008, there is no legal requirement to ensure that the relative don't object, even the doctor or even the donor was a child. We have to put the views of the relative into the grave consideration, and if they are opposed to process, then it may be wise to put their wishes first. What does that mean? I have one patient now has a donor card and the relative refusing. So that we have to try to convince the relative. It is the wishes of the patient. And the patient wants to help others even after he passed away. And he signed this paper when he has full capacity. And this paper is registered in National Health Service. And there is witness about it. It seems that your son or your father is a helping man. And he helped a lot of people. He helped a lot of people in the past, and he wants to continue helping others even he passed away. So that you can convince the relative by this way. Try to touch their heart. This is the most sensitive area to tell one of the relative your son or your father has been died, and at the same time you want to counseling him about organ donation. So you have to enter this area with, as I said, it is called transitional zones. You have to transfer the patient from this criteria, you have to transfer the relative from the grave of this to the sympathy and the empathy for his patient. This is called the transitional zone. After you told him about the brainstem death, before entering in the organ donation area, you have to take the relative with you and try to touch his heart by saying to him, could you tell me more about the social activity of your son? It's very important. Maybe the relative telling you he is a kind man, he was helping, he is helping me and helping other poor people. At this time you ask him, did your son have any wishes or advanced directive? If he told you no or yes, so that you have to answer, it seems that your son was a helping man and he helped a lot of people in the past, as you said to me, and he need also to continue help of the people after he passed away. And this continue helping, I'm sure he makes some notes to document that. It is called organ donation. So that the transitional zone, it is very important to say it between the transfer the patient, the surrogate in front of you from the organ donation to, from the death to the organ donation. So that we'll try to convince him. If they refused, we'll put this in the grave and we'll give him a couple of hours. He can think in this issue and he can come again and discuss this issue with consultant. So that don't confirm him from the first time. It is not legally to refuse the organ donation because your son have a donor card. Try to convince him, give him time to absorb, not 1 week or 2 weeks, it's a couple of hours. So that give him time if the surrogate is insist, and come back again to discuss this issue. Can the donor impose conditions on the use of organ donations? What do you mean by that, doctor? I mean, can the donor specify to whom he will give his organ? Or can the donor specify in nationality to take his organ? No. Neither the donor nor relatives can impose any condition on the use of organs. Organ donation is an open. If he agree for organ donation, so it is allowed to take his organ once he confirmed brainstem death. Can the relatives of the donor refuse donation? If the patient is a registered donor, relatives don't have a legal right to overrule their wishes. We will discuss this matter sensitive, as I said, with the medical staff and encourage to accept the donor wishes. Again, we'll make a zone. One for brainstem death, then transitional zone, then the organ donation. What if the patient wishes are unknown? If the patient wishes not known, then the body will under the Human Tissue Act. The person who owns the body can authorize the removal of organ. This usually is the next of kin of the patient. if the patient doesn't have any advanced directive or leading well, or he doesn't have wishes, and he doesn't have organ donation, then the decision for the next of kin. We can give this authority to the next of kin if the deceased person has no objection to used as organ donor. The relative don't object. There is no any religious considerations. So if the patient wishes, we don't know it, it will be the next of kin will take the decision. But we have 3 criteria to do that. The patient doesn't have any objection, the relative doesn't have any objection, and no religious consideration. Who is the next of kin? It is very important. How can we know the father is the next of kin, or the mother is the next of kin, or the wife is the next of kin? One of the important issues to know that during discussing organ donation, and I will see why after discussing it. What is meant by qualifying relationship? A person in a qualifying relationship can give consent for organ donation on behalf of patient. Yani he is the one will take the decision of organ donation. It's called qualifying relationship. First line will be partner or spouse. Partner or spouse, it's the first next of kin. If it's not there, then parent or a child. Parent or a child. If not there, brother or sister. If not there, grandparent or grandchild. If not there, will be Nevo or stepfather or stepmother, then half brother or half sister, then friend of long standing. This is qualifying relationship. If you concentrate well, you will see that how can I put in my mind the arrangement of qualifying relationship. Put in your mind the arrangement will be the person is close to patient. The closer will be the next of kin. I mean the close to his body, not to his heart. So the closer first is a partner. After that will be parent or a child. After that brother or sister. After that grandparent or grandchild. So the closer to the body, the closer to the heart will be the next of kin. It's an example, it's not a rule. First the partner, then parent or child, brother or sister, grandparent or grandchild, and after that nephew, stepfather or stepmother, half brother and half sister, half brother and half sister, he has different mother or different father. Friend of long standing. This is the next of kin. Why is this important? I would like to say, once upon a time in the past there is a case of organ donation in the exam, and they mentioned for you in the scenario you are discussing the case with the father of the patient, and the patient age is around 33, and he has wife, and his wife is in Australia, and she will come tomorrow, so that the responsibility of the body now to the wife, not to the father in front of you. So concentrate well to ask the patient to ask the relative, are you next of kin? Are you next of kin? It is very important to know the person in front of you, he is a next of kin or no in the organ donation, and this arrangement of the next of kin. Now we spoke about the brainstem death, organ donation in the cadaveric person. Then we will go to discuss living donation. In UK, there is a Human Tissue Act responsible about arrangement of organ donation. And there is an organization, it is called Ultra, not Ultras for the football, it's called Ultra, Unrelated Life Transplant and Unrelated Leaf Transplant Regular Authority, is responsible about non-genetic related person. Non-genetic related person. It's called Ultra. What are the criteria for organ donation in a from living person? Criteria to the donor and criteria to the recipient. For the donor, there is no high risk for the donor. The donor should give a consent. The donor should be volunteer, not any pressure upon him. The donor must understand he or she may withdraw the consent at any time before the procedure. It is called continuity. No payment is made for the donation. There must be a good chance of successful outcome to the recipient. So that we have a criteria for organ donation. One for the donor, like any consent, capacity and informed, volunteer and continuity. We will add there is risk to be low for the donor, and also will add no payment. So that there is 6 criteria for the donor. But there is one criteria for the recipient, it is called successful outcome. This is the criteria for organ donation from the living person. After the organ donation and the recipient of the donation has been assessed by the transplant team, there is one called an independent assessor. It is not in the transplant team. It will come from the Human Tissue Act and will assess the donor, and they will make sure that is all legal requirement for the donation has been met. Another one will come to revise the criteria for organ donation with the donor. 6 criteria should be met, and this will be assessed by independent assessor from Human Tissue Act, and this person not included in the transplant team. This is the organ donation and brainstem death. It is a short lecture, but it is a valuable information. So that if you have a brainstem death patient and you will be going to discuss with the relative, this is the summary. First, you will introduce yourself and identify your relative, confirm the agenda, and ask if he needs any one of relative to become with him. Then first ask how much he know about the patient illness, how much he was informed about the patient illness, and what's your expectation. This is the introduction. Sometimes in the exam you will face that Once you inform the patient, hello, I am Dr. Ahmed, senior house officer in the critical care unit. Are you Mr. Muhammad? Yes, doctor. Hello, doctor. And the patient will ask you suddenly, what's about my son, doctor? I was informed by the nurse my son has admitted to intensive care unit because he collapsed in the school. What about him, doctor? Is if he is okay now? So that the patient will start the scenario before you confirm the agenda. At this time, you can absorb the patient and tell him, I am going to tell you everything about your father. I just want to assure that you are feel comfortable. Then tell him how much you know about your father, about your son illness, and confirm the agenda if you want, and also if you want anyone to attend the meeting. As I said with the start of this lecture, there is a lot of breaking bad news in the brainstem test. So you have to go step by step and explain the events slowly, and every now and then say I am sorry for that, and emphasize about brainstem test is a technically dead. Emphasize about the cell will not recover again. Emphasize about stop of ventilation is not a cause of death because he is already technically dead. But in your mind the patient will be angry because he feels that the lovely person has been died suddenly. Put the reaction of the patient in a grave and try to absorb his as much as you can, and don't go in confrontation, and try to be simple with the patient and with the relative, to emphasize about there is no way he will not come back again. Maybe the patient will ask you, the relative will ask you, I saw a lot of person in such a case and they come back again. You have to define the difference. Maybe the patient, the other doesn't have the same condition. Brainstem death means the brain is died and his autonomic functions will not come again, and his breathing will not start again, or his heart will not beat if we stop this ventilation. Maybe the patient will tell the surrogate will tell you, you will kill my father or my son if you stop this the machine. Tell him again, he is already dead. Stopping the machine will not make any difference, as his brain is died and will not come back again. And continue the machine, it will allow for him to suffer and more, and maybe he will get a lot of complications from continue the machine, by maybe he got infection in the chest, bug in the chest, or bug in the chest and air around the lung, or we will make for him chest compression if his heart to stop, and all of this will not make any difference in the treatment as he already did. And we look for the best interest for the patient and to end his suffering, because continue in this machine, it will allow for him to get more suffering, and the end result will be futile. Try to be also sympathy in such case. If you have in the scenario to discuss the organ donation, so that you have to put the patient in a surrogate in a transitional zone. Try to ask him about the social activity of the patient. Please put this in circle, this information. Don't 3 times. Don't discuss organ donation without convince the relative that his son or the patient is already died. If you will discuss the organ donation with him and he didn't accept that even he is died, it's a big mistake. He didn't agree with you. Now the patient died. How come you will discuss the organ donation? So first you have to finish the subject, the brainstem death, and to convince the relative, and then go to the organ donation. And the organ donation, as we said, there is a transitional zone. You have to pass on this transitional zone before discuss the organ donation. And this transitional zone, it's about social activity, about this person helping others or not. Then ask about advanced patient wishes, advanced directive and living well, and lastly the organ donation. And if the patient has organ donation card, the responsibility to do this, it is for the patient, but we have to convince the relative and not take any confrontation with him if he refusing to do that, and we will discuss this issue for a couple of hours to discuss this issue again with the relative. If no any advanced directive for leaving the will or wishes or organ donation, the next of kin is responsible about the body, and we have to take a consent from him first. This for organ donation. Organ donation from the living person, from the living person, we have criteria, 6 criteria. We have 7 criteria, 6 for the donor and 1 for recipient. The recipient will be successful outcome, donor 4 as consent, and another 2 more low risk for him, and other one will be continuity and capacity and volunteer, and he has to be informed and no any payment for the donor. This is the organ donation and brainstem test. It is very important to understand this well, and also to put in our mind brainstem test and organ donation. It is one of the common case could you encounter it in the exam. Lastly, I would like to thank every person asked about me in the last critical moment for me, and this life we can pass for sometimes with critical moments, but at the same time I would like to thank the other person support me a lot, and they ask about me on the daily basis, maybe 2 or 3 times a day, like a drugs, and I feel better, and alhamdulillah, I passed this one by your prayer and by your asking Allah to help me. Also, I would like to thank Dr. Al-Khatib. As usual, I would like to inform his one will. If me and you in the same station, we will close the gaps. But if me and you in 2 different stations, there will be gap between us. So shoulder to shoulder, it will push us for more and more valuable information and valuable data. Thanks Dr. Khatib for your help and for your support, and I will upload this lecture for you soon, and I hope that as usual you will do the best to deliver this lecture to our candidate. See you in the next lecture. Thank you. See you. Bye bye.